everybody, and welcome back to MooseMed. Welcome to MSK Week 2, where it's just going to be a whole lot of dermatology. We're going to tap on the autoimmune stuff here and there again, and then we're going to wrap around to pharmacology, and then finally end off with some pediatrics. I have to apologize. I am recording this after I finished recording everything else because I realized I was mispronouncing. Who would have guessed? MooseMed mispronouncing something crazy. But I was mispronouncing something really, really poorly. And that thing is urticaria. And the entire time I call it urethrasia for some reason. So urticaria, that is the correct pronunciation for hives. Okay? Urticaria. Again, I'm really sorry. I hope you guys enjoyed the video. Hope it gets you some points. Enjoy your review. Let's jump right into it. There's a lot to cover. All right, so when describing a skin lesion, first decide whether it is flat or raised, and then determine its size. Using the 5 millimeter cutoff in this course, a macule is a flat area of altered pigmentation smaller than 5 millimeters, while a patch is larger than 5 millimeters. A papule is raised, solid lesion smaller than 5 millimeters, whereas a nodule is larger and often extends more deeply into the skin. A plaque is a broad, elevated lesion with a relatively flat top, as classically seen in psoriasis, like plaque psoriasis. And then the same size distinction will apply to fluid-filled lesions, with a vesicle being smaller and a bulla being larger. And then keep in mind that some dermatology references use a 1 centimeter cutoff, but for my material here, we're just going to be sticking to the 5 millimeter convention, which is what's used by my institution. All right, so fluid-filled lesions are classified primarily by their size and contents. A vesicle contains clear or serous fluid and is smaller than 5 millimeters, whereas a bulla is larger than 5 millimeters. A blister is a general clinical term that includes both vesicles and bulla. A pustule is also raised but contains purulent material, usually composed largely of neutrophils. A wheal is different because it results from temporary dermal edema rather than a true fluid-filled cavity. Wheals are raised, erythematous, intensely pruritic, and transient, making urethrasia the classic example. Scale refers to dry flakes of excess stratum corneum on the skin surface and is considered a secondary change rather than a fluid-filled lesion. All right, so other gross skin terms is right, because these are pretty freaking gross. So these terms describe a secondary change or secondary changes that often reveal what has been happening to the skin over time. And excoriation is a traumatic disruption of the epidermis caused by scratching, so linear excoriations can be an important clue that the condition is pruritic. Repeated rubbing or scratching may eventually produce lichenification, in which the skin becomes thick, rough, and leathery with exaggerated skin markings. And then we have onycoliosis, sorry if the pronunciation there is wrong, but onycoliosis describes separation of the nail plate, freaking disgusting, from the underlying nail bed, and can occur with conditions such as psoriasis, trauma, or fungal infection. Do not confuse the cause-based term excoriation with erosion or ulceration. An erosion is a partial loss of the epidermis, whereas an ulcer extends through the epidermis into the dermis and is therefore likely to produce a scar. Yeah, the nail stuff is gross. Let's move on. Yuck. All right, so dermatopathology often begins by recognizing a reaction pattern rather than immediately naming the disease. Acanthosis means epidermal hyperplasia or thickening of the epidermis, while acanthosis is a loss of adhesion between keratinocytes and can create an intraepidermal blister, as in pemphigus. Spongiosis is intracellular epidermal edema that pushes keratinocytes apart while their desmosomal bridges remain visible, and this is the classic pattern of eczematous dermatitis. So hydropic swelling is an intracellular edema rather than edema between the cells, which is what we just talked about. And then you have exocytosis, meaning inflammatory cells have migrated into the epidermis, while vacuolization describes vacuoles forming within or next to the injured cells, often near the dermo-epidermal junction. So these findings are patterns of injury, so they must be interpreted alongside the clinical presentation and the rest of the biopsy. All right, so several microscopic terms describe which epidermal layer has changed. So hyperkeratosis is thickening of the stratum corneum, while hypergranulosis is thickening of the granular layer. Parakeratosis means nuclei are retained in the stratum corneum, suggesting accelerated epidermal turnover, also as classically occurs in psoriasis. And then you have dyskeratosis, which is premature or abnormal keratinization occurring below the granular layer. Then you have papillomatosis, referring to elongated or enlarged dermal papillae that create an underlying or elevated surface. You have a lentigious pattern, which is a linear proliferation of melanocytes along the basal epidermis. And then finally, an erosion is a partial thickness epidermal loss and generally heals without scarring, whereas an ulcer, like we said, represents complete epidermal loss extending into that dermis and can heal with a scar. So freckles, café au lait spots, and lentigines are all flat brown lesions, but their biology differs. A freckle, or ephellus, is a small light brown macule that darkens with sun exposure and may fade during the winter. It results from increased melanin production and transfer to keratinocytes without an increase in melanocyte number. A café au lait spot is a larger, persistent light brown patch whose color is relatively stable. A single lesion can be normal, but multiple lesions should raise concern for underlying syndrome. A high-yield NF1 criterion is 6 or more café au lait macules larger than 5 millimeters before puberty or 15 millimeters after puberty. A lentigo is a sharply defined hyperpigmented lesion with actual increase in melanocytes arranged along the basement membrane, producing the lentigious growth pattern. Pigmented lesions exist along a spectrum ranging from clearly benign lesions to melanoma. Benign examples include the café au lait spots we just talked about, lentigines, common melanocytic nevi, blue nevi, and Spitz nevi, which nevi is just a fancy way of saying mole. A dysplastic nevus occupies an intermediate clinical category because it is primarily a marker of increased melanoma risk and can occasionally serve as a precursor. However, most individual dysplastic nevi do not become malignant, and most melanomas arise de novo rather than from a pre-existing mole. Major melanoma subtypes include superficial spreading, lentigo maligna, acral lentiginous, and nodular melanoma. Melanoma in situ remains confined to the epidermis above the basement membrane. Once malignant melanocytes invade the dermis, the lesion becomes invasive melanoma and gains access to lymphatic and vascular channels, increasing its metastatic potential. All right, so a melanocytic nevus is a benign clonal proliferation of melanocytes known as a nevus cell. And so activating mutations in the MAP kinase pathway, commonly involving BRAF or RAS, which are BRAF or RAS, initially stimulate proliferation. So unlike melanoma, the cells of a benign nevus usually enter oncogene-induced senescence and stop dividing. Nevi are classified by where the cells are located. In a junctional nevus, the nest remain at the dermoepidermal junction, producing a lesion that is usually flat and pigmented. A compound nevus contains cells that are both the junction and within the dermis, so it is commonly raised and pigmented. An intradermal nevus has cells confined to the dermis and is generally raised, but may become lightly pigmented or flesh-colored. This progression helps explain why many moles become more elevated and less pigmented with age. All right, so a major microscopic feature supporting a benign nevus is orderly maturation with depth. So near the surface, nevus cells are relatively large, produce more melanin, and grow in organized nests. As the cells descend into the dermis, they become progressively smaller, contain less pigment, and separate into cords or individual cells. The deepest cells may become spindle-shaped and resemble neural tissue, a change called neurotization. This organized transition from large superficial cells to smaller, less active deep cells is reassuring because it suggests that the cells are differentiating rather than becoming more aggressive. Melanoma often lacks this orderly maturation, so with atypical cells remaining large and proliferative at deeper levels. So loss of maturation is therefore concerning, although it must be interpreted with the lesion's symmetry, cytologic atypia, mitotic activity, and other histological findings. So a blue nevus is a benign lesion composed of heavily pigmented spindle-shaped melanocytes located within the dermis, often accompanied by fibrosis. Because the pigment lies relatively deep, light scattering makes the lesion appear blue, blue-gray, or nearly black. Its dark color can clinically resemble melanoma, but a typical blue nevus is small, symmetric, and stable. A Spitz nevus is another benign melanocytic lesion that most often appears in children or adolescents. And so especially on the face or extremities. So it may grow rapidly before stabilizing and usually appears as a symmetric pink, red, or light brown papule. Histologically, it contains a large spindle-shaped and epithelioid melanocyte or melanocytes, which is why it is called a spindle or epithelioid cell nevus. Spitz nevi can closely resemble melanoma, both clinically and microscopically, so suspicious or atypical lesions require careful pathologic evaluation. So dysplastic nevi can rarely transform into melanoma, but their greater importance is that they identify a patient with an increased overall melanoma risk. Most melanomas still arise de novo rather than from a pre-existing dysplastic nevus, and risk increases as the number of dysplastic nevi increases. Familial atypical multiple mole melanoma syndrome is commonly associated with germline CDKN2A mutation, and CDKN2A encodes P16, which inhibits CDK4 and CDK6 and preserve the tumor suppressor activity of RB. Some lectures describe the familial lifetime risk as approaching 100% in heavily affected families, but current estimates for CDKN2A carriers are high rather than universal. So for the exam, the main association is multiple dysplastic nevi plus a family history of melanoma, suggesting CDKN2A related familial melanoma. All right, so a dysplastic nevus is usually larger than 5 millimeters and may be flat or slightly raised. Compared with common nevus, it is more likely to have an irregular border and variable pigmentation, which can make it clinically resemble melanoma. Microscopically, it is often a compound nevus with architectural disorder. Junctional melanocytic nests may bridge or fuse across adjacent rete ridges, while lentigious melanocytic proliferation extends beyond the underlying dermal component. This extension creates the characteristic junctional shoulder, and then whereas melanin incontinence occurs when pigment escapes into the dermis and is taken up by the macrophages, and a mild lymphocytic infiltrate may also be present. These atypical features justify surveillance, but a dysplastic nevus is not automatically melanoma. So now we're going to do the melanoma ABCs with melanoma, okay? So the ABCDE criteria help identify pigmented lesions that deserve further evaluation. So A stands for asymmetry, meaning one half does not resemble the other. B is an irregular, notched, or poorly defined border. C refers to a color variation, such as different areas of brown, black, red, white, or blue. D is a diameter greater than about 6 millimeters, although melanomas can be smaller. E stands for evolution and includes any new change in size, shape, color, elevation, symptoms, itching, or bleeding. And evolution is especially important because a changing lesion is more concerning than a large but stable and uniform one. These findings are warning signs rather than a diagnostic criteria. When melanoma is suspected, a complete excisional biopsy with narrow margins is preferred when feasible because it allows accurate evaluation of the entire lesion and its depth. Okay? So the ABCs with melanoma. All right, so ultraviolet-induced DNA damage is a major cause of cutaneous melanoma, particularly on intermittently sun-exposed skin, but not every melanoma is related to UV exposure. Melanocytes are also present outside of the typical skin surface, so rare primary melanomas can arise in mucosal locations such as the oral cavity, anogenital regions, GI tract, and genitourinary tracts. So melanoma may also originate in the uvea, very rarely the meninges. Acral melanoma occurs on the palms, soles, and beneath the nails, and is not strongly linked to UV exposure. Actually, this is just like a board fun fact here. So black people with like their amount of melanin in their skin are more resistant to UV damage, right? And so actually the most common form of melanoma that they can still get is the acral melanoma, because it's on the soles of the feet and on the palms of the hand and under the nails, where they have less melanin. So just something to keep in mind. It's something that boards like, and it's something that I've seen show up in my UWorld questions. So just good to know. So most melanomas arise, again, de novo rather than from an existing nevus. So once melanoma begins to invade and its vertical depth is much more prognostically important than how wide it appears on the surface, that's when it becomes a problem, right? It's that depth rather than the actual width of it. Okay, so melanoma risk reflects a combination of UV exposure, pigmentation, genetics, and personal history. So fair skin, poor tanning ability, blonde or red hair, and certain MC1R variants reduce protection from ultraviolet injury. Xeroderma pigmentosum creates an especially high risk because defective nucleotide excision repair prevents effective repair of UV-induced DNA damage. Other major risk factors include blistering sunburns, numerous nevi, dysplastic nevus syndrome, a previous melanoma, a first-degree relative with melanoma, and immunosuppression. Melanoma incidence and mortality are higher overall in men, although risk patterns vary by age and body size. So less common inherited associations include pathogenic variants involving CDKN2A, CDK4, MITF, and BAP1. These factors increase susceptibility, but melanoma can occur in any phenotype and in every skin tone. And here we just have one of the vampires from Twilight. I think her name is Veronica, I'm pretty sure. But she's super high risk for melanoma, right? She's got the ginger hair and basically no melanin. She's a vampire, right? UV is not her friend. So, super high risk for melanoma there. All right, so melanoma develops through increased growth signaling combined with loss of cell cycle control. CDKN2A produces two tumor suppressors through alternative reading frames. The first is P16, which inhibits CDK4 and CDK6, keeping RB active and preventing inappropriate progression from G1 to the S phase. The second is P14 ARF, or ARF, which inhibits MDM2 and thereby stabilizes P53. Activating BRF or NRAS mutations stimulate the MAP kinase pathway and promote proliferation. Loss of NF1 also increases RAS signaling, while the loss of P10 activates the P13K, AKT, mTOR survival pathway. KIT alterations are more characteristic subsets of acral mucosal and chronically sun-damaged melanomas, while GNAQ or GNAQ and GNA11 are strongly associated with uveal melanoma. Finally, TERT promoter alterations increase telomerase activity, helping malignant cells achieve replicative immortality. So melanoma does not follow one universal sequence, but this stepwise model is useful for understanding progression. UV injury can create driver mutations, such as activating the BRAF or RAS alterations, causing melanocyte proliferation. In a benign nevus, oncogene-induced senescence normally stops further growth. Additional TERT or TERT dysregulation can maintain telomerase and allow continued survival. Loss of P16 removes an important CDK4 and CDK6 checkpoint, allowing cells to bypass senescence and supporting invasive vertical growth. Later, loss of tumor suppressors such as P10 or P53 promote survival, invasion, and metastatic behavior. For this lecture's exam, the association to remember is P10 loss as a change linked to progression toward metastatic melanoma, largely through that activation of the P13K AKT pathway. All right, so grossly melanoma commonly displays an irregular border and uneven pigmentation. Histologically, growth is often described in two phases. During radial growth, malignant melanocytes spread horizontally through the epidermis and superficial skin. Vertical growth develops when the cells invade downward and form an expanding dermal tumor, increasing access to lymphatic and vascular channels. The malignant melanocytes are typically larger than a benign nevus cell and have more pleomorphic nuclei, prominent nucleoli, and pagetoid upward spread through the dermis. Unlike benign nevi, melanoma generally lacks orderly maturation with depth. Immunohistochemical stains can confirm melanocytic differentiation. S100 is highly sensitive, while HMB45 highlights many melanocytic tumors. Neither stain alone proves malignancy, so they must be interpreted with morphology and other markers such as SOX10 and Melan A. So Breslow thickness measures the vertical depth of an invasive melanoma in millimeters. It is measured from the top of the epidermal granular layer to the deepest invasive malignant cell. If the surface is ulcerated, measurement begins at the base of the ulcer. Increasing Breslow thickness is associated with greater risk of lymph node involvement, metastasis, and death, making depth far more important than horizontal diameter. Ulceration is another major adverse prognostic feature. Mitotic rate can provide additional prognostic information, although it is no longer used to define the AJCC-T1 subcategories. So a brisk tumor infiltrating lymphocyte response may be reassuring, but the significance of histologic regression is less consistent than what this line implies here. So for staging, prioritize Breslow thickness and ulceration over regression or surface size. All right, so melanoma differs from many carcinomas because it is not routinely assigned a conventional histologic grade. Surface diameter and morphologic variants, such as spindle cell appearance, are also not the primary variables used to determine prognosis. For a localized primary melanoma, the most important pathologic feature are Breslow depth and ulceration. Mitotic activity and host lymphocytic response can provide additional information, but play a smaller role in formal staging. Once melanoma spreads, regional lymph node involvement, in-transit disease, and distant metastasis become dominant prognostic factors. So the high yield principle is that melanoma prognosis depends primarily on how deeply it has invaded and how far it has spread, not simply how wide, dark, or microscopically bizarre the lesion looks. All right, so think of these lesions as a progression in architectural disorder, although a dysplastic nevus does not inevitably become melanoma. A benign nevus is symmetric and organized, may be junctional, compound, or intradermal, and shows maturation with depth as cells become smaller, less pigmented, and sometimes neurotized. A dysplastic nevus is usually larger than 5 millimeters with variable pigmentation and an irregular border. Histologically, it may show bridging of junctional nests, a lentigious shoulder, and melanin incontinence. Its main importance is as a melanoma risk marker. Melanoma shows greater asymmetry, cytologic atypia, pleomorphism, prominent nucleoli, and loss of maturation with depth. It may progress from radial to vertical growth, and once invasive, Breslow thickness becomes a major prognostic measurement. So here's the rapid review. I'm keeping this in. I actually really like this. I think it's a good way to just practice that recall. So here's our first rapid review. So remember that an erosion is partial epidermal loss, while ulceration represents complete epidermal loss with extension into the dermis. Freckles darken with the summer, but do not contain increased number of melanocytes. A lentigo does, okay? A benign nevus matures with depth, producing smaller, less pigmented and neurotized cells. A blue nevus contains heavily pigmented spindle melanocytes in the dermis, while a Spitz nevus classically appears rapidly in a child and contains large spindle or epithelioid cells. Dysplastic nevi are usually larger than 5 millimeters and show irregular pigmentation, bridging, and a lentigious shoulder. Melanoma is suggested by the ABCDE changes and absent maturation. Suspected melanoma is preferably evaluated by excisional biopsy. Prognosis is strongly related to the Breslow thickness, and the lecture here associates metastatic progression with loss of P10 or P53. So the major forms of melanoma. So we have melanoma in situ, which is confined to the epidermis and represents stage 0 disease. Several patterns can exist in situ before becoming invasive. Superficial spreading melanoma generally begins with a prolonged radial growth phase before invading vertically. Nodular melanoma lacks this prolonged radial phase and grows vertically from the beginning, allowing it to become thick relatively quickly. Acral lentigious melanoma occurs on the palms, soles, and nails apparatus and is not strongly associated with UV exposure. Lentigo maligna is the in situ form found on chronically sun-damaged skin, typically the face of an older adult. Invasion converts it into lentigo maligna melanoma, and so a melanotic melanoma produces little visible pigment, while subungual melanoma describes melanoma arising beneath or within the nail apparatus, usually as an acral presentation. All right, so melanoma in situ means malignant melanocytes remain above the basement membrane within the epidermis and dermoepidermal junction. Because there is no dermal invasion, it is classified as stage 0 and has not yet gained access to the dermal lymphatic or vascular channels. Microscopically, the melanocytes show atypia, nuclear enlargement, hyperchromasia, and prominent nucleoli. They may also migrate upward through the epidermis, producing pagetoid or transepidermal spread. In situ patterns include superficial spreading melanoma in situ, acral lentiginous melanoma in situ, and lentigo maligna. The defining distinction is not the surface appearance or subtypes, it's the absence of invasion through the basement membrane into the dermis, okay? So once it's in the dermis, that's bad, okay? Right, so superficial spreading melanoma usually begins with radial growth, meaning malignant cells spread horizontally through the epidermis before developing significant vertical invasion. Clinically, this often produces a flat or slightly raised lesion with asymmetry, irregular borders, and variable pigmentation. Nodular melanoma behaves differently because vertical growth occurs from the beginning without a prolonged radial phase. It commonly presents as a rapidly growing, elevated, firm nodule that may be darkly pigmented, red, or amelanotic, meaning no color. Because it quickly accumulates Breslow depth, nodular melanoma often behaves more aggressively and may not satisfy every classic ABCDE feature. A useful additional warning mnemonic is EFG, elevated, firm, and growing. So acral lentiginous melanoma develops on acral skin, especially the palms, soles, and nail apparatus. It is not strongly associated with ultraviolet exposure, so do not limit melanoma screening to sun-exposed areas. This is the most common melanoma subtype proportionally among Black and Asian patients, although it can occur in any skin tone. Early growth is often lentiginous, with atypical melanocytes spreading along the dermoepidermal junction before deeper invasion develops. Subungual melanoma may appear as a widening or irregular longitudinal pigmented band, nail destruction, or pigmentation extending onto the surrounding nail fold called the Hutchinson sign. Because acral lesions can be overlooked or mistaken for trauma, bruising, or fungal disease, diagnosis is often delayed here. All right, so lentigo maligna is a melanoma in situ arising on chronically sun-damaged skin, usually on the face of an older adult. It is also called a Hutchinson melanotic freckle and typically appears as a slowly enlarging irregular pigmented macule or patch. It may remain confined to the epidermis for many years, often growing gradually over 5 or 20 years or longer. Overall, estimates suggest that fewer than 5% become invasive, although risk is higher in larger, long-standing lesions. Once malignant melanocytes cross the basement membrane and extend into the dermis, the diagnosis becomes lentigo maligna melanoma. The classic exam presentation is an older patient with a slowly changing irregular pigmented facial lesion on chronically sun-exposed skin. So not every melanoma is darkly pigmented. Amelanotic melanoma produces little or no visible melanin and may present as a pink or red macule, plaque, or rapidly growing nodule. It can mimic dermatitis, a vascular lesion, or a non-melanoma skin cancer, which often delays recognition and leads to a greater Barlow depth at diagnosis. Microscopically, pagetoid upward migration of atypical melanocytes can support primary melanoma, although this feature is not completely specific. Metastatic melanoma may also be poorly differentiated and resemble carcinoma, sarcoma, or lymphoma. In difficult cases, melanotic markers such as S100, SOX10, Melan A, and HMB45 help establish the lineage. Melanoma may even be present as metastatic disease without an identifiable primary, possibly because the original lesion regressed and remained occult. All right, so melanoma spreads through both lymphatic and hematogenous routes. So regional lymph nodes are common early sites, and sentinel lymph node biopsies evaluate the first node or group of nodes receiving drainage from the primary tumor. This procedure is primarily used for staging and prognosis in selected clinically node-negative patients. Melanoma may also produce satellite or in-transit deposits within lymphatic vessels between the primary lesion and regional nodes. Once hematogenous dissemination occurs, common distant sites include the lungs, liver, brain, bone, skin, soft tissue, and GI tract. The spinal cord and heart can also be involved. And so occasionally metastatic melanoma is discovered without an obvious cutaneous primary tumor, and in that setting, melanoma should remain in the differential diagnosis of an unexplained nodule, subcutaneous, or visceral malignancy. So Clark levels are an older system that described or describes the anatomic skin layer reached by melanoma. Level 1 is melanoma confined to the epidermis, corresponding to melanoma in situ. Level 2 invades the papillary dermis. Level 3 fills the papillary dermis and approaches the junction with the reticular dermis. Level 4 invades the reticular dermis, and level 5 extends into the subcutaneous tissue. Increasing levels, therefore, mean progressively deeper anatomic invasion. So Clark level has largely been replaced by modern staging by Breslow thickness, which directly measures tumor depth in millimeters and is more reproducible and prognostically useful. So for exams, just know the 5 anatomic levels, but prioritize Breslow thickness and ulceration when asked about current melanoma staging or prognosis. All right, I know we're kind of beating a dead horse with the Breslow stuff, but this repetition is always good for these types of just do you know it or do you not questions, and this is especially the case with like these staging questions, because I could definitely see a vignette where it's like, oh, it's in stage whatever, how far did it invade, right? So anyway, and also this diagram's a little better. So Breslow thickness, as we said, directly measures an invasive melanoma's vertical depth in millimeters, and it is measured from the top of the epidermal granular layer to the deepest invasive melanoma cell, or from the base of an ulcer when the surface is ulcerated. So increasing thickness correlates with the increasing metastatic risk and worsening prognosis, making Breslow thickness more useful than Clark level or horizontal diameter. So the staging table shown here is simplified, a little bit of an older framework, so don't classify modern melanoma stages by depth alone. Current staging also incorporates ulceration, regional lymph nodes, satellite or in-transit disease, and distant metastases. Elevated LDH provides additional adverse prognostic information in metastatic melanoma. And so the essential exam principle here, though, is going to be vertical depth matters much more than surface width. So congenital melanocytic nevi are benign melanocytic proliferations present at birth or appearing shortly afterward. They may begin as pigmented patches and later become thicker, darker, hairy, or nodular. Very large lesions can cover the trunk in a bathing suit distribution, and these nevi result from somatic mosaic abnormalities arising during fetal development, with NRAS mutations being common in large lesions. Melanoma risk is primarily related to projected adult size, so small and medium nevi carry a risk well below 1%, while large and giant nevi carry a higher risk. Additional concerns include numerous satellite nevi and neurocutaneous melanosis. So this lecture's infant measurements are essentially proxies for predicted adult size. So the high yield association is simple here. So the larger the congenital nevus, the greater the melanoma risk. All right, so congenital dermal melanocytosis presents as a flat blue-gray patch, usually over the lower back, sacrum, or buttocks. The older term is Mongolian spot, but congenital dermal melanocytosis is preferred now. So its color results from melanin-producing cells remaining deep within the dermis, where the light scattering produces a blue appearance. So these lesions are more common in infants with Asian, Black, Hispanic, or Native American ancestry, and usually fade during early childhood. Because they can resemble bruises, their location and appearance should be documented at birth. Infantile hemangiomas are benign vascular tumors that frequently become more visible during the first weeks of life, undergo a proliferative phase, and then gradually involute. They may also be mistaken for trauma, but their red vesicular appearance and characteristic growth pattern help distinguish them. A fun fact about the hemangiomas is that I have these cute 2 little twin cousins. There's these 2 little girls, and they're really funny, super energetic, but they do look identical, except one of them has a hemangioma that will most likely regress by the time she's a teenager, but right now she has it just right above her eyebrow, and her mom always jokes that if it wasn't for the hemangioma, she wouldn't be able to tell them apart, which I always think is kind of funny. So a pigmented lesion is not automatically melanocytic or malignant. Benign possibilities include lentigines and junctional compound intradermal blue and Spitz nevi. Dysplastic nevi occupy an intermediate category because they are a melanoma risk marker and occasionally are precursors. Malignant considerations include superficial spreading, nodular, lentigo-maligna, and acrolentigious melanoma. Non-melanocytic lesions such as seborrheic keratosis, pigmented basal cell carcinoma, actinic keratosis, and dermatofibroma can also mimic melanoma. Evaluate the lesion symmetry, border, color distribution, evolution, and relationship to the patient's other moles. And so histologically assess cytologic atypia and maturation with depth. Color alone cannot establish the diagnosis, so an evolving or otherwise suspicious lesion requires appropriate biopsy. So non-pigmented lesions range from harmless growths to skin cancer. So common benign examples include seborrheic keratosis, skin tags, lipomas, dermatofibromas, epidermoid cysts, cherry angiomas, and pyogenic granulomas. Clinical clues can help. A lipoma is soft and mobile, and a dermatofibroma dimples with lateral compression. An epidermoid cyst may have central punctum, and a pyogenic granuloma is friable and bleeds easily. Okay, so actinic keratosis is a precursor to squamous cell carcinoma, while keratocanthoma is generally managed as a form of squamous cell carcinoma rather than simply observed. Basal cell carcinoma often appears pearly and ulcerated with telangiectasias, whereas squamous cell carcinoma is commonly scaly, keratotic, or indurated. Always remember that amelanotic melanoma, all right, so no color melanoma, can also present as a pink or red lesion, all right? So amelanotic just means no melanin, which is commonly brown. So seborrheic keratosis is a common benign epidermal tumor that usually develops in middle-aged or older adults. It appears as a raised, waxy brown or warty lesion with a classic impression that it has been quote-unquote stuck onto the skin. Lesions are especially common on the trunk and may be mistaken for warts, nevi, or melanoma. Microscopically, seborrheic keratosis contains proliferating basaloid keratinocytes with acanthosis, hyperkeratosis, and keratin-filled horn cysts or pseudohorn cysts. Activating alterations involving FGFR3, PIK3CA, or RAS pathways are common, but the lesion remains benign and is not caused by HPV. The key pathology association is basaloid cells plus the horn cysts, okay? If the clinical appearance is atypical or changing, biopsy may still be needed to exclude malignancy. Okay, we have some French, so bear with me. So the lesser trilat or trilat sign describes the abrupt eruption of rapid enlargement of numerous seborrheic keratoses, often accompanied by itching. It is classically considered a paraneoplastic sign of an internal malignancy, especially gastric adenocarcinoma. Although colorectal, breast, lung, and hematologic cancers have also been reported. The critical clue is sudden change over a short period, not the presence of several stable seborrheic keratoses in an older adult. The validity of lesser trilat as a specific paraneoplastic syndrome is debated because both seborrheic keratoses and cancer become more common with age. Even so, a truly explosive eruption, particularly with weight loss, GI symptoms, or malignant acanthosis nigricans, should prompt evaluation for an underlying malignancy. So acanthosis nigricans presents as velvety, thickened, hyperpigmented skin in flexural areas such as the posterior neck, axilla, groin, and anogenital region. Most cases are associated with obesity and insulin resistance, including type 2 diabetes and polycystic ovary syndrome. High insulin concentrations stimulate insulin-like growth factor receptors on keratinocytes, promoting epidermal proliferation. Rare familial forms can result from activating FGFR3 mutations, but FGFR3 is not the typical mechanism of common obesity-related disease. A sudden extensive onset in an older adult, especially involving the mouth or accompanied by trypanosomes and weight loss, raises concern for malignant acanthosis nigricans. And so the classic associated malignancy is GI adenocarcinoma, particularly gastric adenocarcinoma. All right, so an acrochordin, also called a skin tag or a fibroepithelial polyp, is a soft, skin-colored or mildly pigmented lesion that usually hangs from a narrow stalk. It commonly develops in friction-prone folds such as the neck, axilla, and groin. Microscopically, it consists of loose fibrovascular core covered by epidermis. Acrochordins are completely benign, but occur more frequently in people with obesity, type 2 diabetes, and insulin resistance. Multiple skin tags can therefore support suspicion for a metabolic syndrome, although they are not diagnostic by themselves. The differential includes a neurofibroma, which show a buttonhole sign, a seborrheic keratosis with a stuck-on surface, and a pedunculated melanocytic nevus. Treatment is usually unnecessary unless the lesion becomes irritated or is removed for cosmetic reasons. So an epidermal inclusion cyst, more accurately called an epidermoid cyst, is a keratin-filled cavity lined by stratified squamous epithelium. Most arise from an obstructed follicular infundibulum, while some develop when trauma implants epidermal cells into the dermis. Clinically, the cyst appears as a discrete nodule that is usually mobile over deeper tissues, but may remain attached to the surface through a visible central punctum. It commonly occurs on the face, neck, or trunk. Rupture releases keratin into the dermis and triggers an intense foreign body inflammatory reaction, which can resemble infection. Multiple epidermoid cysts occurring early or in an unusual location should raise concern for Gardner syndrome, an autosomal dominant APC association variant, or familial adenomatous polyposis that also features osteomas, desmoid tumors, and very high colorectal cancer risk. All right, so cherry angiomas are the benign vascular lesion that appears as a small, smooth, dome-shaped red papule, and these lesions are usually only a few millimeters across and are most commonly found on the trunk and the proximal extremities. Because these are composed of proliferating blood vessels, they may bleed if scratched or otherwise injured, but cherry angiomas become more numerous with increasing age and generally require no treatment unless they bleed, become irritated, or removed for cosmetic reasons. All right, so adnexal tumors arise from the skin's appendages and are classified according to the type of structure they resemble. So this includes eccrine or apocrine sweat gland differentiation, hair follicle or hair matrix differentiation, and sebaceous differentiation. Both benign and malignant tumors occur within these categories, but the complete classification system is not worth memorizing at this stage. Instead, focus on the recurring exam clues here. So the lesion's characteristic location, its clinical and microscopic appearance, its associated mutation, and whether it points to an inherited cancer syndrome. So here are those high-yield adnexal tumor associations. So for the adnexal tumors, memorize the strongest pairings here. So an eccrine peroma commonly appears on the palm or sole, while syringiomas present as multiple small papules around the lower eyelids. A sebaceous adenoma can be a marker of Muir-Torrey syndrome, a variant of Lynch syndrome that connects sebaceous tumors with mismatch repair deficiency and internal malignancy. Pilomatricoma shows hair matrix differentiation and is associated with activating CTNNB1 or beta-catenin mutations. Cylindromas favor the scalp and forehead and are associated with loss of the CYLD tumor suppressor gene. And then, so those are the high-yield ones, and then we're going to break down cylindroma in a little bit more detail, and then it's time for that rapid exam review. All right, so a cylindroma is a usually benign adnexal tumor that most commonly develops on the scalp or forehead. When numerous tumors enlarge and merge across the scalp, they may form the classic hat-like turban tumor. Microscopically, cylindromas contain islands of basaloid cells surrounded by a thick basement membrane material, with the islands fitting together like pieces of a jigsaw puzzle. Multiple cylindromas suggest CYLD, cutaneous syndrome, an autosomal dominant disorder caused by an inactivating CYLD mutation. The exam association is therefore scalp tumors, jigsaw puzzle histology, and CYLD. So now time for that exam review. So here are the major associations to keep straight. So superficial spreading melanoma grows radially before invading vertically, whereas nodular melanoma enters vertical growth early. Acrolentigious melanoma involves the palms, soles, or nail beds, while lentigo-maligna melanoma classically occurs on the chronically sun-damaged face of an older patient. Melanoma confined to the epidermis is melanoma in situ, and Breslow thickness is the preferred measure of invasion. A large congenital nevus carries greater melanoma risk, and blue-gray pigmentation over the infant's lower back back suggests dermal melanocytosis or Mongolian spots. A stuck-on lesion with horn cysts is seborrheic keratosis. A sudden eruption suggests the lesser Trellat sign. Multiple epidermal inclusion cysts suggests Gardner syndrome. A sebaceous adenoma suggests Muratori syndrome. And then a pilomatrachoma pairs with CTNNB1, and a turban cylindroma pairs with CYLD. All right, so actinic keratosis is a UV-induced keratinocytic lesion found on chronically sun-exposed skin, especially the face, bald scalp, ears, forearms, and back of the hands. It typically feels rough or gritty like sandpaper and may appear red, tan, or brown. Microscopically, atypical keratinocytes are concentrated in the lower epidermis, while maturation is retained closer to the surface. Parakeratosis and solar elastosis may also be present. So UV-related DNA damage, including TP53 abnormalities, drives this process. Most individual lesions never become invasive, but actinic keratoses indicate substantial cumulative sun damage and an increased risk of squamous cell carcinoma. So the simplified histological distinction is depth of epidermal atypia. In actinic keratoses, atypical keratinocytes usually occupy only the lower portion of the epidermis, with maturation still present in the upper layers. So in squamous cell carcinoma in situ, also called Bowen disease, atypia and disordered maturation extend through the full thickness of the epidermis. Neither lesion has invaded the dermis, but once malignant squamous cells cross that basement membrane and infiltrate the dermis, the diagnosis becomes invasive squamous cell carcinoma. Keratinization and intracellular bridges help establish squamous differentiation. All right, so keratoacanthoma is a rapidly growing dome-shaped nodule with a characteristic center crater filled by a keratin plug. It usually develops on sun-exposed skin and can closely resemble a well-differentiated squamous cell carcinoma. Although some keratoacanthomas spontaneously regress, their behavior is unpredictable, and many experts classify them as squamous cell carcinoma. Except with the subtype of keratoacanthoma. So for that reason, they are generally managed as squamous cell carcinoma. Diagnosis requires a sufficiently deep and broad specimen that preserves the crateriform architecture. A superficial shave may be inadequate here, and a complete excision is often preferred. All right, so squamous cell carcinoma in situ usually presents as a persistent red scaly plaque. The malignant keratinocytes occupy the full thickness of the epidermis, but have not invaded the dermis. Invasive squamous cell carcinoma, or SCC, may become a firm papule, plaque, or nodule with hyperkeratoses, crusting or ulceration. It commonly develops on sun-exposed areas such as the face, ears, lips, and dorsal hands. Squamous cell carcinoma can also arise within a chronic wound, burn scar, or non-healing ulcer. This is called a Marjolian ulcer and carries a greater metastatic risk than routine sun-associated squamous cell carcinoma. Microscopically, invasive squamous cell carcinoma contains nests or cords of atypical squamous cells that cross the basement membrane and extend into the dermis. Well-differentiated tumors retain recognizable squamous features, including intracellular bridges and keratin pearls, which are concentric collections of keratin produced within tumor nests. Poorly differentiated tumors show greater pleomorphism and mitotic activity with less obvious keratinization. The high-yield combination is dermal invasion, intracellular bridges, and focal keratinization, which strongly supports invasive squamous cell carcinoma. All right, so chronic ultraviolet exposure is the major cause of cutaneous squamous cell carcinoma, producing mutations in genes such as TP53 and Notch, or NOTCH. Other risks include arsenic and chemical carcinogens, defective nucleotide excision repair, and xeroderma pigmentosum, HPV infection, and immunosuppression, especially following solid organ transplant. Squamous cell carcinoma can also develop in chronic burn scar or non-healing ulcer, where it is called a Marjolin ulcer. Most routine cutaneous squamous cell carcinomas remain localized, but tumors arising in scars, high-risk locations, or immunosuppressed patients behave more aggressively and carry a greater risk of recurrence and metastasis. All right, basal cell carcinoma is the most common human malignancy and usually develops on sun-exposed skin, particularly the face. The classic presentation is a slowly growing pearly papule with visible surface telangiectasias, sometimes with central ulceration. Microscopically, it contains nests of basaloid cells with peripheral palisading of the nuclei and retraction spaces between the tumor nests and surrounding stroma. Unlike squamous cell carcinoma, it does not form keratin pearls or show prominent squamous keratinization. Basal cell carcinoma is locally invasive and can cause substantial tissue destruction, but metastasis is exceptionally rare. So basal cell carcinoma is driven by inappropriate activation of the hedgehog signaling pathway. Normally, the PTCH1 or PITCH1 tumor suppressor protein inhibits smoothened or SMO. When PITCH1 is lost, that inhibition disappears, allowing SMO or smoothened and downstream GL1 transcription factors to stimulate cellular proliferation. An inherited PITCH1 defect causes Gorlin syndrome, also called nevoid basal cell carcinoma syndrome. These patients develop numerous basal cell carcinomas at an unusually young age and may also have jaw keratocysts and palmoplantar pits. The core exam association is multiple early onset basal cell carcinomas, Gorlin syndrome, PITCH1 loss, and hedgehog activation. And by the way, the hedgehog pathway, it does have a component called sonic, which I think is funny. This is like complete biochemistry. You do not need to know this, so just skip ahead if you don't care. But there is an enzyme in this pathway called sonic, and I just think it's funny because it is named after Sonic the Hedgehog, which is pretty cool. All right, so to separate squamous cell carcinoma and basal cell carcinoma, look for keratinization. Squamous cell carcinoma commonly presents as a red, scaly, hyperkeratotic, or ulcerated lesion. Histology shows invasive squamous cells with intracellular bridges and keratin pearls, and some tumors can metastasize. Basal cell carcinoma is classically a pearly papule with telangiectasias. Histology shows basaloid nests with peripheral palisading and stromal retraction without keratin pearls. Basal cell carcinoma is linked to PITCH1 loss and hedgehog activation, and both tumors can be locally destructive, but metastatic spread is considerably more characteristic of squamous cell than basal cell. And you can just remember that, squamous spread. Okay, there you go. All right, so Merkel cell carcinoma is a rare but highly aggressive cutaneous neuroendocrine carcinoma. It typically presents in an older or immunosuppressed patient as a rapidly enlarging, painless, firm to red, violaceous nodule on sun-exposed skin, commonly the head and neck. It has a strong tendency to spread early to regional lymph nodes. Microscopically, it is a small, round blue cell tumor with scant cytoplasm, numerous mitoses, and neuroendocrine differentiation. Many cases are associated with Merkel cell polyomavirus, and a useful pathology clue is a dot perinuclear CK20 staining, usually with negative TTF1, which helps distinguish it from metastatic small cell carcinoma of the lung. So a dermatofibroma, or benign fibrous histocytoma, is a benign dermal proliferation that most often appears as a small, firm papule on the lower extremity of a young or middle-aged adult, particularly a woman. So lateral compression causes the center to sink inward, producing the characteristic dimple sign. Histologically, spindle-shaped fibroblastic cells surround and entrap collagen bundles at the lesion's edge. Dermatofibromas are usually a factor 8A positive and CD34 negative. That immunostaining pattern helps distinguish them from dermatofibrosarcoma protuberans, which is typically strongly CD34 positive. All right, so dermatofibrosarcoma protuberans, or DFSP, is a low-grade fibroblastic malignancy that presents as a slowly enlarging plaque or cluster of nodules, commonly on the trunk. Microscopically, uniform spindle cells grow in a storiform or pinwheel pattern and infiltrate the subcutaneous fat, trapping fat cells in a characteristic honeycomb pattern. Most tumors contain a COL1A1 PDGFB fusion caused by a translocation between chromosomes 17 and 22, and this produces continuous PDGF receptor signaling. DFSP rarely metastasizes, but it is locally infiltrative and commonly recurs if incompletely removed. So, complete margin-controlled excision is important. Unresectable fusion positive disease may respond to imatinib, which we will get into the pharmacology at the very end. I have the whole pharmacology boogaloo like we did last time. All right, so dermatofibroma versus DFSP, or dermatofibrosarcoma protuberans. So dermatofibroma is a small benign circumscribed lesion that favors the lower extremity and demonstrates a positive dimple sign. Its spindle cells characteristically entrap peripheral collagen and it is usually CD34 negative. DFSP, or dermatofibrosarcoma protuberans, is a larger, slowly growing plaque or nodule that commonly occurs on the trunk. It is locally aggressive, extends into subcutaneous fat in a honeycomb pattern, and contains spindle cells arranged in a storiform pattern. DFSP is strongly CD34 positive and usually carries COL1A1 PDGFB fusion. The quick distinction is dimple sign and collagen entrapment for dermatofibroma versus honeycomb fat infiltration and PDGFB activation for dermatofibrosarcoma protuberans. All right, so mycosis fungoides is the most common form of cutaneous T-cell lymphoma and classically consists of malignant CD4 positive helper T cells with a preference for the epidermis. It often begins with slowly progressive pruritic erythematous patches in the sun-protected areas and can resemble eczema for years. Disease may progress from patches to thicker plaques and eventually to cutaneous tumors. Microscopically, atypical lymphocytes show epidermotropism and cerebriform or brain-like nuclei. Small intraepidermal clusters of malignant T cells are called Potrier microabscesses and are the classic exam clue. Okay, so it's Potrier microabscesses are going to be your little clue for mycosis fungoides. All right, so Sézary syndrome is the leukemic form of cutaneous T-cell lymphoma. The classic triad is generalized as erythroderma, lymphadenopathy, and malignant Sézary cells circulating in peripheral blood. So patients commonly have intense pruritus, scaling, alopecia, and diffuse redness involving most of the body. The malignant T cells have the same cerebriform nuclei seen in mycosis fungoides, but the central distinction is that mycosis fungoides usually begins as skin-predominant patch, plaque, or tumor disease, whereas Sézary syndrome requires significant blood involvement with widespread erythroderma and generally carries a worse prognosis. All right, so mastocytosis is a group of disorders characterized by an abnormal accumulation of mast cells in the skin, internal organs, or both. So symptoms result from both tissue infiltration and release of mediators such as histamine and tryptase. Cutaneous mastocytosis is more common in children and often appears as erythrasia pigmentosa with multiple tan or reddish-brown lesions. Systemic mastocytosis is more common in adults and may involve the bone marrow, spleen, liver, gastrointestinal tract, and bone. The major molecular association is an activating KIT mutation, KIT, classically KIT D816V, which promotes mast cell survival and proliferation. A classic finding in mastocytosis is the Darrier sign. Rubbing or scratching a lesion triggers mast cell degranulation, causing localized redness, itching, swelling, or formation of a wheal. Mediator release can also produce generalized pruritus, flushing, abdominal cramping, diarrhea, hypotension, or even anaphylaxis. Systemic infiltration may cause hepatosplenomegaly, cytopenias, bone pain, and osteoporosis. Serum tryptase can help evaluate suspected systemic disease. And so for an exam question, connect brown skin lesions that become swollen when rubbed with mastocytosis, and connect systemic symptoms such as flushing, GI complaints, and bone pain with mast cell mediators and activating KIT mutation. All right, so acanthosis describes disorders of keratinization that produce dry, thickened, fish scale-like skin because normal shedding of the stratum corneum is impaired. The most common inherited form is acanthosis vulgaris, usually caused by a loss-of-function mutation in Sjögren, or FLG, and inherited in the autosomal dominant pattern. It commonly affects the extensor surfaces while sparing the flexors. X-linked acanthosis results from steroid sulfatase deficiency and primarily affects males. When acanthosis begins for the first time in an adult, consider an acquired cause rather than an inherited disorder. Important associations include medications, endocrine disease, HIV, and malignancy, classically Hodgkin's lymphoma. All right, so acute inflammatory dermatoses develop over days to weeks and commonly feature arrhythmia, edema, pruritus, and some degree of epidermal injury. The visible lesions may include papules, plaques, vesicles, or bullae, but the microscopic reaction pattern helps narrow the diagnosis. So urotrazia primarily produces edema in the dermis, acute eczematous dermatitis produces spongiosis, meaning intracellular edema within the epidermis. Arrhythmia multiforme produces an interface reaction with lymphocytes near the dermal epidermal junction and apoptotic keratinocytes. And the high-yield approach is to combine the lesion's appearance and duration with its location, trigger, and dominant histological pattern. And we'll break these down in the following slides here. The urotrazia, I got this a lot as a kid, and I have a funny story about it. But first, business. So urotrazia presents with transient, intensely pruritic wheals caused by mast cell mediator release and superficial dermal edema. The lesion may be erythematous or pale, vary in size and shape, and usually disappear from particular location within 24 hours without leaving a mark. New wheals may continue to appear elsewhere, so the overall episode can last much longer. Angioedema involves deeper tissue and commonly affects the lips, eyelids, hands, or airway, and histology shows dermal edema separating collagen bundles with relatively sparse perivesicular inflammation. A lesion that remains fixed for more than 24 hours becomes painful or leaves bruising. Leaving bruising should raise concern for an alternative diagnosis such as urotracheal vasculitis. So urotrazia in general, I got this a lot as a kid, whether when it was a stress response or when I got too overheated. But basically, I had this teacher who was like this very old school catty gay man. He was like he had a lot of sass. Like he would literally just insult students coming through the door based on their outfit. He just hit like the casual, I wouldn't wear that, stuff like that. And I loved him to death. His name was Mr. Slayton. Shout out Mr. Slayton. And I remember I was sitting in the back of the classroom taking an exam, and I got a little nervous for one reason or another. And so my urotrazia started spiking up, and it starts on my arm, and it started to work my way up my shoulder, and it literally looks like a topographical map just on your arm. It looks pretty nasty. And so I was walking by, and so I take off my sweatshirt, and I'm wearing a t-shirt because I was getting overheated. And so it's now spreading all the way up my arm while I'm taking this test, and Mr. Slayton walks by, and he sees my arm, and he sees like this urotrazia basically going all the way up my arm, and he looks at it, and he just gives it like this nasty little side eye, and he goes, "Ew, what is that?" Like just mid-exam, everybody's quiet taking their exam, and he just loudly goes, and I'm like, oh, it's just hives. I get them when I just get overheated. And he goes, "Is it contagious?" And I go, "No." And he goes, "Okay, well, keep it away from me." And I don't know. It's just funny. It sounds like he bullied me. I swear to God, he was such a sweetheart. He just had a little bit of spice in him. But yeah, the urotrazia, I don't know, just cracks me up. I never knew it was called urotrazia until med school, but here we are. So I always just called them hives. Good times. All right, so acute urotrazia may be triggered by viral infections, food, medications, pollen, insect venom, or physical stimuli such as cold pressure and heat. That's me. Some episodes are classic type 1 hypersensitivity reactions in which allergen-specific IgE causes mast cell degranulation. Others are non-IgE mediated. So radiographic contrast can directly activate mast cells, while aspirin and other NSAIDs can provoke urotrazia through COX-1 inhibition and increased leukotriene signaling. Chronic spontaneous urotrazia is frequently autoimmune or idiopathic, rather than the result of a specific external allergen. Second-generation H1 antihistamines are generally first-line therapy, while any airway involvement, hypotension, or other evidence of anaphylaxis requires immediate emergency treatment. All right, acute eczematous dermatitis produces intensely pruritic erythematous papules and plaques that may form vesicles, rupture, ooze, and develop crust. The characteristic microscopic finding is spongiosis or intracellular edema between epidermal keratinocytes. Severe spongiosis can create the small vesicles seen clinically. Major causes include allergic contact dermatitis, irritant contact dermatitis, atopic dermatitis, drug eruptions, and photoinduced reactions. Allergic disease is immune-mediated, whereas irritant dermatitis results from direct epidermal injury and does not require prior sensitization. As eczema becomes chronic, repeated rubbing and inflammation produces acanthosis, hyperkeratosis, and lichenification, creating thickened skin with exaggerated surface markings. So allergic contact dermatitis is a type 4 delayed hypersensitivity reaction. After a patient has been sensitized, re-exposure activates antigen-specific T lymphocytes and usually produces dermatitis within 24 to 72 hours. The eruption is pruritic, erythematous, and often papulovesicular, with oozing or crusting in more severe cases. Its distribution frequently provides the strongest clue because it begins where the allergen contacted the skin. Common examples include nickel jewelry, poison ivy, fragrances, hair dyes, and topical antibiotics. Histology shows spongiosis. Patch testing can identify the responsible allergen in recurrent or chronic cases, and the essential treatment is avoidance. Irritant contact dermatitis differs because it represents direct injury and can occur with the first exposure. So, erythema multiforme is an acute immune-mediated interface dermatitis characterized by classic target lesion with concentric zones of color change. The eruption usually is symmetric and favors acral or extensor surfaces, including the hand and feet. Herpes simplex virus is the most common trigger, although other infections and occasionally medications may be responsible. CD8 positive cytotoxic T cells injure keratinocytes, producing apoptosis and lymphocytes along the dermal-epidermal junction. Erythema multiforme is generally self-limited and resolves over several weeks. Mycoplasma-associated disease with prominent mucositis is now often classified as a reactive infection, mucocutaneous eruption, or RIME, rather than being grouped automatically with classic erythema multiforme. So erythema multiforme is distinct from the Stevens-Johnson syndrome and toxic epidermal necrolysis spectrum. Erythema multiforme is usually infection-associated and produces raised classic target lesions on the extremities with limited skin detachment and little or no mucosal disease. Stevens-Johnson syndrome and TEN are usually medication-induced and present with fever, systemic illness, painful dusky macules or atypical flat targets, prominent mucosal erosions, and full-thickness epidermal necrosis. Classification is based on detachment or detachable body surface area. Stevens-Johnson syndrome involves less than 10%. Overlap involves 10 to 30%, and TEN or TEN involves more than 30%. Stevens-Johnson syndrome and TEN are medical emergencies requiring immediate withdrawal of the culprit drug and intensive supportive care. Right, so now we're just going to compare them based on their mechanism, right? So these disorders can be separated by identifying both the immune mechanism and the level of skin injury. So urotrazia results from mast cell mediator release, producing superficial dermal edema and transient wheals with minimal epidermal damage. Some acute cases are classic IgE-mediated type 1 hypersensitivities, but urotrazia can also arise through non-IgE mechanisms. Allergic contact dermatitis is delayed type 4 hypersensitivity reaction mediated by sensitized T cells. It produces spongiosis, meaning intracellular epidermal edema, along with intensely pruritic papules, vesicles, and oozing. Erythema multiforme involves cytotoxic T cell injury to keratinocytes and classically produces target lesions. Toxic epidermal necrolysis represents the most severe epithelial injury with full thickness epidermal necrosis, widespread skin sloughing, and prominent mucosal involvement. Now time for the rapid exam review here. So here are the major diagnostic anchors from the section. So a rough sun-exposed lesion with atypia limited to the lower epidermis is actinic keratosis, while full-thickness atypia without invasion is squamous cell carcinoma in situ, a rapidly growing crater-form lesion with a central keratin plug suggests keratoacanthoma, I hate that one. Keratin pearls and intracellular bridges identify squamous differentiation, and squamous cell carcinoma arising in chronic wound is called a Marjolin ulcer. Basal cell carcinoma is the pearly papule with telangiectasias, peripheral palisading, and pitch 1 related hedgehog activation. A dimple sign suggests dermatofibroma, whereas storiform growth, honeycomb fat infiltration, and COL1A1 PDGFB fusion suggests DFSP, which is that dermatofibrosarcoma protuberans. Remember mycosis fungoides for progressive skin plaques with cerebriform CD4 T cells, Sézary syndrome for erythroderma with circulating malignant T cells, and mastocytosis for KIT activation with a positive Darrier sign. So chronic inflammatory dermatoses persist for months to years and commonly produce rough, thickened, or scaly skin. The major entities here are psoriasis, seborrheic dermatitis, lichen planus, and lichen simplex chronicus. So psoriasis produces sharply demarcated plaques with silvery scale, usually on extensor surfaces. Seborrheic dermatitis produces greasy scale in areas rich in sebaceous glands, particularly the scalp, eyebrows, and ears. Lichen planus produces pruritic purple polygonal papules, oh my god, say that 5 times fast, with an interface dermatitis pattern microscopically. Lichen simplex chronicus is the result of repeated rubbing or scratching and therefore produces localized lichenification. On the exam, distinguish these disorders by combining lesion color and surface with distribution, immune mechanism, and microscopic reaction pattern rather than just relying on any single feature. So classic plaque psoriasis presents with sharply demarcated erythematous or salmon-colored plaques covered by adherent silvery white scale. So the distribution is typically symmetric and favors the extensor elbows and knees, scalp, lumbosacral area, and gluteal cleft. Genital and flexure psoriasis may appear smoother because moisture reduces the visible scale. Nail involvement can produce pitting, separation of the nail plate, disgusting from the nail bed, oh my god, ew. Subungual hyperkeratosis or yellow-brown oil drop discoloration. So psoriasis is strongly associated with HLA-C star 602, although multiple genes and environmental triggers contribute here. So always ask about joint pain, stiffness, or swollen digits because psoriasis may be accompanied by psoriatic arthritis, which is just arthritis, or it's just rheumatoid arthritis with now psoriasis. So the combination of an extensor distribution, sharply defined plaques, and silvery scale is the core clinical pattern here. Psoriasis pathogenesis. So psoriasis is an immune-mediated inflammatory disorder driven largely by the IL-23 and Th17 pathway with additional contributions from Th1 cells, epidermal CD8 positive T cells, and TNF-alpha. These immune cells release cytokines that stimulate keratinocyte proliferation and recruit additional inflammatory cells. Epidermal turnover becomes dramatically accelerated, so immature keratinocytes accumulate at the surface and form thick, scaly plaques. Trauma may injure a new psoriatic lesion at the injured site, which is called a Koebner phenomenon. Other triggers can include infections, stress, and certain medications. Guttate psoriasis, for example, may follow streptococcal infection. The major concept is that psoriasis is not simply excessive skin production, it is immune activation that drives excessive keratinocyte proliferation and persistent inflammation. All right, so microscopically, psoriasis produces regular psoriasiform acanthosis with elongated red ridges extending downward in a uniform pattern. Rapid epidermal turnover causes parakeratosis, meaning nuclei are retained in the stratum corneum along with thinning or loss of granular layer. So neutrophils may collect within the stratum corneum to form Monroe microabscesses, but the epidermis becomes unusually thin over the tips of the dermal papillae, where the superficial capillaries are dilated. And this explains the Auspitz sign. Removing the scale will expose these vessels and produce pinpoint bleeding. So the high-yield pathologic combination is regular acanthosis, parakeratosis, hypogranulosis, suprapapillary thinning, and neutrophils in the stratum corneum. So seborrheic dermatitis is a chronic relapsing inflammatory disorder affecting areas rich in sebaceous glands. It typically produces ill-defined erythema with greasy yellow or white scale on the scalp, eyebrows, glabella, nasolabial folds, external ear canals, and skin behind the ears. Infants may develop the familiar scalp presentation called cradle cap. The cause is multifactorial, but an inflammation response to Malassezia yeast appears to contribute. Severe or unusually extensive disease may occur in patients with HIV or neurological disorders such as Parkinson's disease. Distribution is the major diagnostic clue here, so greasy scale around the scalp, face, and ears favors seborrheic dermatitis, while sharply demarcated silvery plaques on extensor surfaces favor psoriasis. So treatment commonly includes a topical antifungal, sometimes combined with a brief anti-inflammatory therapy. So lichen planus is remembered by the classic Ps: pruritic, purple, polygonal, planar, or flat-topped papules and plaques. So lesions commonly involve the flexor wrist, ankles, genital skin, and oral mucosa. Fine white dots or lacy lines on the lesion surface are called Wickham striae. Oral disease may produce a reticular lace-like pattern, lace-like white pattern, or painful erosions. The underlying mechanism is CD8 positive T-cell injury directed against basal keratinocytes at the dermal-epidermal junction. So lichen planus may also demonstrate the Kobner phenomenon with new lesions developing along sites of trauma. So the exam-ready combination is a pruritic, a polygonal papule, Wickham striae, and possible oral involvement. So, if your vignette is reading like a Dr. Seuss poem, pruritic, purple, polygonal, planar, papules, and plaques, it's a good sign that it's probably lichen planus. All right, so lichen planus produces an interface or lichenoid dermatitis centered at the dermal-epidermal junction. A dense band-like lymphocytic infiltrate damages basal keratinocytes, producing basal degeneration and apoptotic cells called civate bodies. The red ridges may develop a pointed sawtooth appearance, while hypergranulosis and hyperkeratosis contribute to the white Wickham striae seen clinically. Damage to the basal keratinocytes can allow melanin to escape into the dermis, where it is taken up by macrophages, and this pigment helps explain the persistent post-inflammatory hyperpigmentation that may remain after active lesions resolve. So for exam questions, connect purple polygonal pruritic papules and Wickham striae with band-like interface inflammation, basal injury, sawtooth red ridges, and civate bodies. All right, so lichen simplex chronicus is the skin's response to an ongoing itch-scratch cycle. So repetitive rubbing and scratching produce a localized thickened plaque with rough surface and exaggerated skin markings, a change called lichenification. So lesions occur in areas the patient can easily reach, such as the neck, wrists, forearms, ankles, shins, scalp, or genital region. Pigment alteration and excoriations may also be present. Histology shows hyperkeratosis, hypergranulosis, irregular acanthosis, and chronic dermal inflammation reflecting repeated mechanical injury. So the disorder may begin with another itchy condition, but continued scratching eventually sustains the lesion itself. So management, therefore, requires treating an underlying cause of pruritus while breaking the itch-scratch cycle with anti-inflammatory and anti-pruritic therapy. All right, so the fastest way to approach a blistering disorder is to determine where the skin is separating at. So an intraepidermal split leaves only a thin blister roof, producing the fragile, flaccid bullae seen in pemphigus vulgaris. A subepidermal split leaves the entire epidermis as the roof, producing a tense, durable bullae seen in bullous pemphigoid, dermatitis herpetiformis, and some forms of epidermolysis bullosa. Next, ask whether acantholysis, meaning loss of adhesion between keratinocytes, is present. Finally, integrate the immunofluorescence pattern, mucosal involvement, age, and clinical associations. And these features are far more useful than trying to just memorize every blister disease as an isolated list. So pemphigus is caused by IgG autoantibodies against desmylogens, where which are adhesion proteins within desmosomes. When desmosomal adhesion is disrupted, keratinocytes separate from one another in a process called acantholysis, and this creates an intraepidermal, usually suprabasal blister with a thin roof. So the bullae are flaccid and rupture easily, often leaving painful erosions. Pemphigus vulgaris commonly involves the oral mucosa and may present with oral erosions before obvious skin disease. On direct immunofluorescence, IgG and complement surround individual keratinocytes in a net-like fishnet or chicken wire pattern. Remember that this intracellular pattern distinguishes pemphigus from the linear basement membrane staining of bullous pemphigoid. All right, so pemphigus vulgaris is the most important and common form. It produces fragile bullae and erosions involving both skin and mucous membranes. Pemphigus vegetans is a rare variant that produces large, moist, vegetating plaques, especially in flexure areas such as the axilla and groin. Pemphigus fallacius produces a much more superficial split, so intact blisters may be difficult to see. Patients instead develop crusted and scaly lesions on the face, scalp, chest, and back with little to no mucosal involvement. Pemphigus erythematosus is a localized superficial variant that often affects the malar region. For exam purposes, the major distinction is vulgaris with mucosal disease versus fallacious with superficial skin disease. All right, so the difference between pemphigus vulgaris and fallacious reflects the desmyelin targeted and the depth of the epidermal split. So pemphigus vulgaris primarily targets desmyelin 3 and may also target desmyelin 1, producing suprabasal acantholysis, flaccid bullae, and frequent mucosal involvement. Pemphigus fallacius primarily targets desmyelin 1, creating a very superficial split near the stratum granulosum. So because mucosal epithelium contains enough desmyelin 3 to maintain adhesion, mucosal disease is uncommon in fallacious. Clinically, vulgaris causes painful oral erosions and fragile skin bullae, whereas fallacious more often produces superficial crusting and scaling without significant oral lesions. All right, so bullous pemphigoid is usually seen in older adults and is caused by IgG autoantibodies against hemidesmosomal proteins, particularly BP180, also known as a type 17 collagen, and BP230. Hemidesmosomes anchor basal keratinocytes to the basement membrane, so their disruption separates the entire epidermis from the dermis. This produces subepidermal blister with a thick roof and therefore tense, stable, and often intensely pruritic bullae. Histology commonly shows eosinophils, but acantholysis is absent because keratinocytes remain attached to one another. Direct immunofluorescence demonstrates linear IgG and C3 along the basement membrane, so mucosal disease is less common than in pemphigus vulgaris, and healed bullae generally do not scar. And again, I said it in the last video, but just in case you're hopping in on week 2 without seeing the week 1, first of all, how dare you rob me of views? But secondly, easy way to remember bullous pemphigoid is it's bullous, it's big. So it's gonna break up the hemidesmosomes, which anchor, right, that which anchor the dermis, right? So when I think bullous, I think big. It's going to destroy the lower decks, right? Whereas pemphigus vulgaris, it's a lot lighter sounding, right? And it's going to attack desmyelin 1 and 3, and it's going to make very, very, very flaccid bullae, right? Okay, because it's a lot lighter. It's a lot on top. Okay. So anyway, it's kind of like a weird little memory way to remember it, but it works for me. So hopefully it works for you. All right, so gestational pemphigoid is a pregnancy-associated autoimmune blistering disorder that usually begins during the second or third trimester. It commonly starts with intensely pruritic urotracheal plaques around the umbilicus and may progress to tense bullae. Like bullous pemphigoid, it is caused by autoantibodies against hemidesmosomal proteins, particularly BP180, producing a subepidermal split. Immunofluorescence typically shows linear C3, often with IgG, along the basement membrane, and this disease may flare around the time of delivery, but usually resolves after childbirth. So the high-yield presentation is a pregnant patient in the later stages of pregnancy with a periumbilical inflammation, followed by tense blisters. You want to be thinking gestational pemphigoid. This is basically just like bullous pemphigoid, a little milder. It could get as bad, but with a pregnant lady. Dermatitis herpetiformis. We've covered this a ton on here, but We covered it again in week 2, so here we are again. So dermatitis herpetiformis is a markedly pruritic blistering disorder strongly associated with gluten-sensitive celiac disease. So patients develop grouped papules and small vesicles in a blisteral symmetric distribution, especially on the extensor elbows and knees, buttocks, scalp, and upper back. Because the lesions itch so intensely, excoriation may be more visible than intact vesicles. IgA antibodies related to gluten sensitivity target epidermal transglutamase in the skin, although anti-tissue transglutamase and anti-endomysial antibodies are useful markers of associated celiac disease. So GI symptoms may be mild or absent, and the classic diagnostic combination is a pruritic extensor vesicle, celiac disease, and granular IgA deposition in the dermal papillae. So microscopically, dermatitis herpetiformis begins with a collection of neutrophils at the tips of the dermal papillae, forming papillary microabscesses. Vascular injury develops along the dermal epidermal junction, and progression eventually creates a subepidermal blister. Direct immunofluorescence is the key diagnostic test and shows granular IgA deposits at the tips of the dermal papillae. This is different from the intracellular fishnet IgG of pemphigus and the linear basement membrane IgG and C3 of bullous pemphigoid. So for the best diagnostic buzzword high yield thing, right? Immunofluorescence is performed on normal appearing skin immediately adjacent to a lesion rather than on a damaged center of an old blister. All right, so pemphigus produces flaccid bullae because of the split. Because the split is within the epidermis, right? So it features acantholysis and intracellular fishnet IgG around keratinocytes, with mucosal disease being especially common in pemphigus vulgaris. Bullous pemphigoid produces tense bullae because the separation is below the epidermis, and it has no acantholysis, often contains eosinophils, and shows linear IgG and C3 along the basement membrane. Dermatitis herpetiformis also creates a subepidermal blister, but it presents with intensely pruritic grouped vesicles on symmetric extensor surfaces. Histology shows neutrophils at the dermal papillae, and immunofluorescence shows granular IgA, and so the association with celiac disease is the major clinical clue there. All right, so epidermolysis bullosa describes inherited structural disorders in which minor friction or trauma produces blistering, often beginning in infancy or childhood. The subtype depends on the level of skin separation. So epidermolysis bullosa simplex usually involves mutations in keratin 5 or keratin 14 within the basal keratinocytes, producing a relatively superficial split that often heals with limited scarring. Junctional epidermolysis bullosa separates within the basement membrane zone and may involve proteins such as laminin 332 or collagen 17. Dystrophic epidermolysis bullosa results from COL7A1 mutations and defective type 7 collagen, disrupting anchoring fibrils below the basement membrane. Because the split is deeper, dystrophic disease is more likely to cause scarring, milia, contractures, and significant chronic complications. So porphyrias are disorders of heme synthesis, but only the cutaneous forms produce photosensitive skin disease. Accumulated porphyrins absorb light and generate reactive oxygen species, damaging the skin and producing subepidermal blisters on sun-exposed skin. Porphyria cutanea tarda is the classic blistering form, presenting with fragile skin, vesicles, and bullae, especially on the backs of hands, that may heal with scarring and hyperpigmentation. Histology may show a relatively non-inflammatory subepidermal blister with thickened superficial dermal vessels. One important distinction is that the acute intermittent porphyria produces neurovisceral attacks without photosensitive skin findings, while erythropoietic protoporphyria more often causes burning and arrhythmia than true blisters. Acne vulgaris is a disorder of the pilosebaceous unit that is especially common during adolescence and usually affects the face, chest, and upper back. Its hallmark lesion is the comedone. And an open comedone or blackhead contains a follicular keratin plug exposed to the surface. Its dark color results from oxidation and not pigment, or not trapped dirt either, oxidation. So a closed comedone or whitehead has a blocked follicular opening and no visible central plug. If the follicle ruptures, its contents enter the dermis and generate inflammatory papules, pustules, nodules, or cysts. Androgens and medications such as corticosteroids can worsen acne by increasing sebaceous activity or altering follicular keratinization. All right, so acne develops through 4 interacting processes: abnormal follicular keratinization, increased sebum production, colonization by Cutibacterium genes, or acnes, sorry, not genes, and inflammation. Excess keratin blocks the follicular opening and creates a microcomedome, while androgen stimulation enlarges the sebaceous glands and increases sebum production. Cutibacterium acne thrives within this lipid-rich environment and produces enzymes and inflammatory signals that irritate the follicle. When the follicular wall ruptures, keratin, sebum, and bacteria spill into the dermis, producing inflammatory papules and pustules. Deeper or recurrent inflammation can form nodules and cysts, increasing the risk of permanent scarring. This explains why acne treatment often targets more than one part of this pathway. Rosacea is a chronic inflammatory and vascular disorder of the central face that usually begins in middle-aged adults. It may start with episodic flushing and then progress to persistent arrhythmia invisible telangiectasias. Some patients develop inflammatory papules and pustules, but unlike acne, rosacea does not produce comedones. Advanced disease may cause rhinophyma, which is permanent thickening and enlargement of the nasal skin and sebaceous tissue. The pathogenesis involves abnormal innate immune signaling, including increased cathepsin activity and altered processing by kallikrein 5. So along with vascular hyperactivity. So the easiest exam distinction, just basically getting rid of all that fluff, is adolescent comedones for acne versus an older patient with flushing, telangiectasias, and no comedones for rosacea. All right, so panniculitis refers to inflammation of the subcutaneous adipose tissue. Because the inflammation is deep, patients usually develop tender nodules that may be easier to feel than to see. Pathologists classify panniculitis by whether inflammation mainly involves the fibrous septa between fat lobules or fat lobules themselves, and by whether vasculitis is present, or vasculitis, not vesiculitis. Vasculitis is present. Erythema nodosum is the classic septal panniculitis without vasculitis, while erythema induratum is generally a lobular panniculitis associated with vasculitis and tissue necrosis. Other causes include infection, trauma, lupus, pancreatic disease, and malignancy. So when panniculitis is suspected, the biopsy must extend deeply enough to include subcutaneous fat, or the diagnostic pattern may be missed. So erythema nodosum is a reactive septal panniculitis that usually causes bilateral tendus, erythematous nodules, on the anterior lower legs. So the nodules generally do not ulcerate and may fade through bruise-like color changes. It is thought to represent a delayed hypersensitivity reaction to a systemic trigger. Common associations include streptococcal infection, tuberculosis, inflammatory bowel disease, pregnancy, medications such as sulfonamides, and occasional malignancy. Histologically, inflammation is concentrated in the septa between the fat lobules, and a true vasculitis is usually absent. When erythema nodosum appears, the important clinical step is to identify the underlying infection, inflammatory disorder medication, or other trigger rather than treating it as an isolated skin disease. So the microscopic appearance of erythema nodosum, nodosum, I keep saying nodosum, depends on when the lesion is biopsied. Early lesions show septal edema, fibrin deposition, and predominantly neutrophilic inflammatory infiltrate. As the lesion ages, neutrophils are replaced by lymphocytes, macrophages, and multinucleated giant cells, eventually producing septal thickening and fibrosis. Small collections of histocytes surrounding a central cleft, called Meissner radial granulomas, can support the diagnosis. So despite the changing inflammatory population, the process remains primarily septal and typically lacks destructive vasculitis. So this time-dependent pattern is important on exams. So an acute tender leg nodule may show edema, fibrin, and neutrophils, while an older lesion may appear more granulomatous and fibrotic. So erythema induratum, also called erythema induratum of Bazine, but that's a whole ass sentence. So we're just going to call it erythema induratum, or nodular vasculitis. Produces recurrent tender nodules that classically involve the posterior calves. So unlike erythema nodosum, these lesions frequently ulcerate and may heal with scarring. Histologically, it is generally a lobular paniculitis with vasculitis, fat necrosis, and granulomatous inflammation. Caseous necrosis may appear in tubular culeosis-associated disease. So it has traditionally been considered a hypersensitivity reaction to Mycobacterium tuberculosis, although similar nodular vasculitis can occur without proven tuberculosis. The high-yield contrast is that erythema nodosum involves the septa, usually lack vasculitis, and rarely ulcerates, while erythema induratum involves the lobules, includes vasculitis and necrosis, and commonly ulcerates. All right, so verruca are benign proliferations of keratinocytes caused by cutaneous human papillomavirus, or HPV. Verruca vulgaris produces rough raised papules, commonly on the hands and around the nails. Verruca plana produces smoother, flat-topped lesions on the face or palms, while plantar and palmar warts appear as callus-like lesions on pressure-bearing surfaces. Plantar warts may become black dots representing thrombosed capillaries and characteristically interpret normal skin lines. Microscopically, warts show epidermal hyperplasia, papillomatosis, hyperkeratosis, prominent keratohyalian granules, and coilocytes. So the HPV types responsible for common cutaneous warts are generally different from high-risk oncogenic types, and many warts spontaneously regress as cell-mediated immunity develops. Fun fact, verruca, and this is how you can remember that it's HPV associated, is the name of the annoying rich brat from Willy Wonka and the Chocolate Factory. And that's why her name is Verruca. They literally named her Wart. Veruca Salt, that one, the one that gets lost with the chipmunks in the Johnny Depp one. I think that, or not chipmunks, squirrels. And I think the squirrels are also in the Gene Wilder one. I'm not sure. I need to rewatch those. Great movies. Both great. I haven't seen Wonka yet. I don't know. I'm not really a Chalamet head, but we'll see. He might win me over. Maybe I'll do that today. Okay, molluscum contagiosum. We've also covered this one a lot, but here we are again. It is caused by a large DNA pox virus and commonly affects children through direct contact or auto-inoculation. Adults may develop anogenital lesions through sexual transmission. The classic finding is a small, firm, pearly, or skin-colored papule with central umbilication. Immunosuppressed patients may develop unusually large or numerous lesions. Histologically, the epidermis grows downward in a cup-shaped pattern and contains large eosinophilic cytoplasmic inclusions called molluscum bodies or Henderson-Patterson bodies. These inclusions become prominent in the upper epidermis as infected keratinocytes mature. So most cases are self-limited, but the combination of multiple umbilicated papules and characteristic intracytoplasmic inclusions make the diagnosis highly testable. And again, it's caused by pox virus. This one's easy for me to remember because I had it as a kid. I actually still have scars on my elbow, on my anterior elbow, which is exactly where this image is showing it, which is why I chose it. It's nasty stuff. Really unpleasant. Yeah. All right, so impetigo. So impetigo is a highly contagious superficial bacterial infection that commonly affects the face and hands, especially in children. A lesion typically begins as a red macule and quickly develops into a pustule. And when the pustule ruptures, it leaves a shallow erosion covered by that classic honey-colored crust. The major organisms are Staph aureus and Strep pyogenes. Histologically, neutrophils accumulate just beneath the stratum corneum, creating a subcorneal pustule. Because this infection remains superficial and does not involve the dermis, it generally heals without scarring. So the key clinical association is a child with contagious honey-crusted lesions around the mouth or nose. I have a professor that always says impetigo's impetigo, and now every time I see this, I can never unhear his voice saying impetigo in that way. I don't know. Not helpful at all. I just thought I'd share because it's a burden that I only carry. It's a hard life. Guys. So bullous impetigo and pemphigus falacius share disruption of desmyelin 1 and adhesion protein concentrated in the superficial epidermis. In bullous impetigo, an exfoliative toxin produced by Staph aureus cleaves desmyelin 1, producing superficial epidermal separation, fragile bullae, and erosions. Pemphigus falacius produces a similar level of separation, but the mechanism is autoimmune. So IgG antibodies target desmyelin 1 and cause superficial acantholysis. Because desmyelin 1 is most important near the skin surface, both disorders produce shallow, easily ruptured lesions. So mucosal disease is uncommon in pemphigus falacius because other adhesion proteins help maintain the oral epithelium. So the name of a tinea infection usually identifies its location. So tinea capitis affects the scalp of children and may cause scaling, broken hairs, and alopecia. Tinea barbara involves the beard. Tinea corporis affects the body and commonly forms an annular lesion with a scaly advancing border. And tinea cruris affects the groin. So tinea pedis produces scaling and arrhythmia of the feet, while nail involvement is called tinea unguium or onychomycosis. And then tinea versicolor is different because it is caused by the yeast Malassezia rather than a dermatophyte. So it produces finely scaling hypo or hyperpigmented macules, usually on the upper trunk. All right, so several skin findings can serve as clues to an internal malignancy. So acanthosis nigricans produces velvety hyperpigmented thickening in flexural areas such as the neck and axilla. It is commonly related to that insulin resistance, but sudden extensive disease in an older adult should raise concern for an underlying GI adenocarcinoma, especially gastric cancer. Adult onset dermatomyositis can also be paraneoplastic, so an appropriate malignancy evaluation may be warranted. Sweet syndrome presents with fever, neutrophilia, and painful red plaques caused by a dense neutrophilic infiltrate. It is particularly associated with hematologic malignancies, and so the general clue is the abrupt appearance of an unusual or severe inflammatory skin disorder. For an annular lesion, examine the border, scale, and clinical context. Tinea corporis has scaly advancing edge with central clearing. Arrhythmia migrans expands following a tick bite, while arrhythmia marginatum is a transient migrating rash associated with rheumatic fever. Granuloma annular forms a ring of firm papules without the peripheral scale of tinea, and erythemia multiforme produces true target lesions. For folliculopapular eruptions, acne is suggested by comedones in adolescence. Rosacea occurs later in life with central facial flushing and telangiectasias, but no comedones. And then folliculitis centers directly on hair follicles, while perioral dermatitis produces small papules around the mouth, often sparing the vermilion border, aka your lips. All right, so papillosquamous disorders are distinguished mainly by distribution, scale, and associated findings. A diffuse eruption with a herald patch followed by lesions along the skin cleavage lines suggests pityriasis rosea. Guttate psoriasis produces numerous small drop-like scaly lesions, often after a streptococcal infection. Secondary syphilis should be considered when a diffuse eruption involves the palms and soles. Localized papillosquamous eruptions include eczematous dermatitis, which is usually pruritic and may ooze. Candidal interrigo, which affects moist folds and has satellite pustules, plaque psoriasis, which with sharply demarcated silver-scaled plaques, and seborrheic dermatitis, which favors the scalp, face, and other sebaceous areas. So begin a blister differential by asking whether the blister is tense or flaccid and whether the patient has mucosal disease. Bullous pemphigoid causes that tense subepidermal bullae, while pemphis vulgaris produces flaccid intraepidermal bullae and commonly involves the mouth. Epidermomyolysis bullosa presents early in life with trauma-induced blistering. Infectious causes include painful dermatomal vesicles from varicella zoster, grouped vesicles from herpes simplex, honey-crusted erosions from impetigo, and diffuse superficial sloughing in staph scalded skin syndrome. So deep, tender nodules suggest inflammation of the dermis or subcutaneous fat, including erythema nodosum, lupus paniculitis, You got infectious paniculitis, and then trauma-related paniculitis, and sarcoidosis. So here's your rapid exam review. So keep the major pattern recognition clues organized here. So psoriasis produces that silver-scaled extensor plaque, Monroe micro abscesses, the Kobner phenomenon, and punctate bleeding with scale removal called Auspitz sign, right? Those are those pinprick bleeds. Then you have lichen planus, which causes purple pruritic polygonal papules with Wickham striae. Pemphigus produces flaccid intraepidermal bullae with acanthos and acantholysis, whereas bullous pemphigoid produces tense subepidermal bullae with a linear basement membrane staining. Dermatitis herpetiformis combines pruritic extensor vesicles, celiac disease, and granular IgA. Acne features comedones in adolescence, while rosacea produces flushing and telangiectasias later in life. Tender shin nodules suggest erythema nodosum. Ulcerating paniculitis suggests erythema induratum. Honey-colored crusts suggest impetigo, and umbilicated papules suggest molluscum contagiosum. All right, so connective tissue disorders can be divided broadly into inherited structural diseases and autoimmune or inflammatory diseases. Inherited disorders include Ehlers-Danlos syndrome, Marfan syndrome, Stickler syndrome, and osteogenesis imperfecta. Each result from a defect in structural components such as collagen or fibrillin, producing characteristic combinations of joint, skeletal, ocular, vascular, and skin findings. The autoimmune group includes systemic lupus erythematosus, antiphospholipid syndrome, systemic sclerosis, inflammatory myopathies, and mixed connective tissue disease. The inflammatory arthropathies include psoriatic arthritis, ankylosing spondylitis, reactive arthritis, and arthritis associated with inflammatory bowel disease. And so the organizing question is whether the presentation reflects a lifelong structural defect or an acquired immune attack affecting multiple organs. Ehlers-Danlos syndrome represents a group of inherited disorders involving collagen structure, synthesis, and processing. The classic findings are joint hypermobility, hyperextensible skin, easy bruising, poor wound healing, and thin, atrophic scars, often described as cigarette paper scars. The inheritance pattern and affected collagen vary by subtype, but classic Ehlers-Danlos syndrome is usually associated with abnormalities of type 5 collagen and prominently affect the skin and joints. Vascular Ehlers-Danlos syndrome involves type 3 collagen and is especially important because it can cause spontaneous rupture of arteries, intestines, and or the uterus. Therefore, the major clinical distinction is between primary hypermobile phenotype and a vascular fragility phenotype with potentially life-threatening complications. All right, so the Baton score is a screening tool for generalized joint hypermobility. It evaluates fifth finger extension, thumb to forearm movement, hyperextension of the elbows and knees, and the ability to place both palms flat on the floor. However, a high score alone does not diagnose Ehlers-Danlos syndrome. The overall phenotype, family history, and subtype specific criteria also matter here. So complications include recurrent dislocations, chronic musculoskeletal pain, hernias, pelvic organ prolapse, and poor wound healing. Vascular EDS, or Ehlers-Danlos syndrome, is particularly dangerous because fragile arteries, intestines, and uterus may rupture, and so management emphasizes physical therapy, joint protection, avoidance of high-impact activity, genetic counseling, and surveillance based on the specific subtype. Marfan syndrome is an autosomal dominant connective tissue disorder caused by mutations in FBN1, which encodes fibrillin 1. Abnormal fibrillin weakens connective tissue and increases TGF-beta signaling, and so the classic patient is tall and thin with disproportionately long extremities, arachnodactyly, pectus deformity, scoliosis, joint laxity, and high arched palate. One useful clue is an arm span greater than height, so specifically when skeletal findings occur with cardiovascular or ocular disease. So the diagnosis is not based on body habitus alone because several disorders can produce a Marfanoid appearance. So the major concern is whether the patient has aortic root disease or ectopia lentis, which strongly supports the true Marfan syndrome. And the ectopia lentis is talking about the eye association here, and you can just remember it's when the eye is looking up, and I just remember that Marfans, you see Marchans, so you see Martians, right? So it's the eye involvement there that will help differentiate it from Ehlers-Danlos, as well as the fibrillin mutation of FBN1. All right, so the most dangerous complication of Marfan syndrome involves the cardiovascular system. So progressive aortic root dilation can cause aortic regurgitation, aneurysm, or life-threatening dissection, while mitral valve prolapse may also occur. Ocular disease classically includes ectopia lentis, usually with upward and outward lens displacement, along with severe myopia and increased risk of retinal detachment. Additional complications include spontaneous pneumothorax and dural ectasia. And then management centers on serial imaging of the aortic root, reduction of aortic wall stress with beta blocker or angiotensin receptor blocker, and prophylactic surgery when the aorta reaches a high risk size. Patients should also avoid intense isometric exercise that sharply increases blood pressure. So Ehlers-Danlos and Marfan syndromes can both produce joint laxity, but their distinguishing features are different. Ehlers-Danlos syndrome is more strongly associated with hyperextensibility or fragile skin, easy bruising, poor wound healing, atrophic scars, and generalized joint hypermobility. Certain subtypes, especially vascular Ehlers-Danlos syndrome, can cause arterial or hollow organ rupture. Marfan syndrome instead produces a marfanoid skeletal habitus with long limbs and fingers, along with ectopia lentis and aortic root dilation and dissection. Genetically, Marfan syndrome is associated with that FBN1, whereas Ehlers-Danlos represents a group of disorders involving different collagen protein and collagen processing pathways. On an exam, abnormal skin and scarring favors Ehlers-Danlos, while aortic root disease plus lens displacement with that Martian mnemonic I gave you favors Marfan syndrome. All right, Stickler syndrome is usually an autosomal dominant collagen disorder commonly involving type 2 collagen. It can produce mid-face hypoplasia, severe myopia, retinal detachment, hearing loss, joint hypermobility, and early onset osteoarthritis. Some patients develop the Pierre-Robin sequence, and this begins with micrognathia, or an abnormally small mandible, which allows the tongue to fall backward into the glossotosis. And so the displaced tongue can obstruct the upper airway and interfere with normal palate closure, so the cleft palate is frequently present. So the immediate concern in an infected infant is airway protection, while long-term care requires ophthalmologic, audiologic, craniofacial, and skeletal surveillance. The combination of facial abnormalities, major eye disease, hearing loss, and early arthritis should suggest Stickler syndrome. Autoimmune testing should begin with the clinical presentation rather than large indiscriminate panel. ANA is a sensitive screening test for lupus, but it is not specific and may be positive in another autoimmune disease or healthy individuals. ESR and CRP indicate inflammation but do not identify its cause. Notably, CRP may remain normal during an uncompromised lupus flare. Low C3 and C4 can reflect immune complex consumption, and falling complement may support active lupus, particularly lupus nephritis. Rheumatoid factor and anti-CCP support rheumatoid arthritis, but anti-CCP is more specific, and these tests modify the probability of a diagnosis, and they should always be interpreted alongside symptoms, examination findings, organ involvement, and the pre-test likelihood of disease. Some high-yield autoantibodies for exams. So several autoantibodies have especially useful disease association. So in lupus, anti-double-stranded DNA is relatively specific and is associated with nephritis and disease activity, while anti-Smith is highly specific but less useful for monitoring. Anti-Rho or SSA is associated with neonatal lupus and congenital heart block, and anti-LA or SSB is seen in Sjögren syndrome and may accompany neonatal lupus. In systemic sclerosis, anti-centromere antibodies favor limited disease, anti-CSL70 is associated with diffuse disease, and interstitial lung disease and anti-RNA polymerase III increases concern for scleroderma renal crisis. Anti-Jo1 suggests anti-synthetase syndrome, while high-titer anti-U1-RNP is the classic antibody associated with mixed connective tissue disease. All right, so inflammatory pain is typically worst after inactivity. Patients may report morning stiffness lasting longer than 30 to 60 minutes, improvement with movement, nighttime awakening, and associated swelling, warmth, or systemic symptoms. Mechanical pain behaves in the opposite way, so activity and repetitive loading makes it worse. Rest provides relief, and morning stiffness is usually brief. Mechanical disease also generally lacks systemic inflammation, and this distinction is especially important when evaluating back pain. A young adult with chronic back or buttock pain that improves with exercise, worsens with rest, and causes prolonged morning stiffness should raise concern for an axial spondyloarthropathy rather than simple muscular strain or degenerative disease. All right, spondyloarthropathies are a group of usually rheumatoid factor negative inflammatory disorders that include ankylosing spondylitis, psoriatic arthritis, reactive arthritis, and arthritis associated with inflammatory bowel disease. Shared features include inflammatory back pain, sacroiliitis, enthesitis, enthesitis at tendon or ligament insertions, dactylitis, and acute anterior uveitis. Many patients carry HLA-B27, and the disorder may cluster within families, but HLA-B27 is a risk marker rather than a diagnostic test by itself. Disease can be predominantly axial, affecting the sacroiliac joints and spine, or predominantly peripheral, and so the clinical pattern and associated findings such as psoriasis, preceding infection, bowel disease, or uveitis help identify the specific member of the group. All right, so psoriatic arthritis can present in several patterns, including asymmetric oligoarthritis, symmetric polyarthritis, resembling rheumatoid arthritis, distal interphalangeal joint disease, axial disease, or the severely destructive arthritis mutilans pattern. So helpful clues include current psoriasis, a family history of psoriasis, nail pitting, or onycholysis, which is that nail separation, disgusting, ew, enthesitis, and dactylitis producing a swollen sausage digit. So involvement of the distal interphalangeal joints alongside nail disease is particularly suggestive of psoriatic arthritis, but most patients are rheumatoid factor negative, although a positive result does not absolutely exclude the diagnosis. Importantly, the arthritis may occasionally develop before obvious skin lesions, so the scalp, umbilicus, gluteal cleft, and nails should be examined carefully for subtle psoriasis. All right, so psoriatic arthritis is classified using features such as current or previous psoriasis, a family history of psoriasis, nail dystrophy, a negative rheumatoid factor, dactylitis, and newborn formation near a joint. Treatment depends on disease patterns. NSAIDs may control mild symptoms, while conventional DMARDs are used for persistent peripheral arthritis. More severe disease or active axial involvement may require TNF or IL-17 inhibitors. But skin and joint disease should be treated together, and abrupt withdrawal of systemic glucocorticoids should be avoided when possible because psoriasis may rebound. Ankylosing spondylitis typically presents in a young adult with chronic inflammatory lower back pain. Unlike mechanical pain, the morning stiffness improves with activity, and patients may report alternating buttock pain from sacroiliitis. Progressive disease reduces spinal mobility and chest expansion as the axial skeleton becomes increasingly rigid. Important extra-articular manifestations include acute anterior uveitis, aortic regurgitation, and apical pulmonary fibrosis. The inflamed and fused spine is also vulnerable to vertebral fractures. Sorry, that's not funny. My cat is just chewing on my ankles right now. The inflamed and fused spine is also vulnerable to vertebral fractures, so new spinal pain after even minor trauma deserves careful evaluation. So sacroiliitis is the defining imaging feature of ankylosing spondylitis. Early in the disease, plain radiographs may still be normal, while MRI can detect active inflammation and bone marrow edema. Later findings including erosion, sclerosis, fusion of sacroiliac joints, and the classic bamboo spine appears just later on. Daily exercise and physical therapy are essential for maintaining posture and mobility, with NSAIDs used first line for symptoms. Persistent active disease may require TNF or IL-17 inhibitors. Remember the central contrast. Inflammatory back pain improves with movement, whereas mechanical back pain generally worsens with activity. All right, so both Crohn's disease and ulcerative colitis can be associated with peripheral or axial arthritis. Type 1 peripheral disease is an acute asymmetric oligoarthritis of the lower extremities that usually parallels intestinal activity. Type 2 is a more chronic polyarthritis that may continue independently of bowel symptoms. Axial disease includes sacroiliitis and ankylosing spondylitis and also tends to behave independently of intestinal activity. And then management includes controlling the underlying IBD and using physical therapy for axial disease. NSAIDs must be used cautiously, while selected monoclonal TNF inhibitors can treat both the intestinal and joint manifestations. Systemic lupus erythematosus is a chronic autoimmune disease caused by loss of self-tolerance and immune complex-mediated injury. Common manifestations include constitutional symptoms, a symmetric inflammatory polyarthritis, photosensitivity, a malar rash, painless oral or nasal ulcers, non-scarring alopecia, and Raynaud's phenomenon. Systemic lupus erythematosus most commonly affects women of reproductive age. More severe disease is observed in several racial and ethnic populations through a complex combination of genetic, environmental, socioeconomic, and healthcare factors. Because lupus can affect nearly any organ, the clinical presentation can vary widely between patients. So lupus can produce clinically important disease in multiple organs. So renal involvement may cause proteinuria, hematuria, or cellular casts, but lupus nephritis can initially be silent, making routine urine and kidney function testing essential. Neurologic disease may present with seizures, psychosis, cognitive changes, or peripheral neurologic abnormalities. Cardiopulmonary findings include pleuritis, pericarditis, Liebman-Sachs endocarditis, and accelerated atherosclerosis. Hematologic abnormalities include autoimmune hemolytic anemia, leukopenia, or lymphopenia, and thrombocytopenia. When evaluating lupus, always look beyond the skin and joints for evidence of organ-threatening disease. So hydroxychloroquine is recommended for most patients with lupus unless contraindicated, along with sun protection, appropriate vaccination, and cardiovascular risk reduction. Mild skin or joint disease may be treated with topical therapy, NSAIDs, or brief courses of low-dose glucocorticoids. Moderate or severe disease often requires an immunosuppressive or biologic medication with the goal of minimizing long-term steroid exposure. Organ-threatening disease may require high-dose glucocorticoids plus stronger immunosuppression. Lupus nephritis is commonly treated with agents such as mycophenolate or cyclophosphamide. Patients taking hydroxychloroquine require regular retinal toxicity screenings because of that bullseye loss of vision that is iconic as an adverse reaction for hydroxychloroquine. So antiphospholipid syndrome causes recurrent arterial or venous thromboses and pregnancy complications such as recurrent fetal loss, placental insufficiency, or premature birth. The major antibodies are lupus anticoagulant, anti-cardiolipin, and anti-beta-2 glycoprotein 1. Diagnosis requires at least one qualifying clinical event plus persistent antibody positivity on tests performed at least 12 weeks apart, so a positive antibody test alone is not sufficient. The classic paradox is that lupus anticoagulant may prolong the PTT in the laboratory while producing hypercoagulability inside the patient. Thrombotic disease generally requires long-term anticoagulation. So reactive arthritis is a sterile inflammatory arthritis that develops after an infection elsewhere in the body. Common triggers include chlamydia, salmonella, shigella, campylobacter, and yersinia. The classic joint pattern is an acute asymmetric oligoarthritis of the lower extremities, often accompanied by enthesitis. So other findings can include urethritis or cervicitis, conjunctivitis, or anterior uveitis, oral ulcers, and keratoderma blennoragatum. My gosh, I'm not trying to pronounce that. That is a word and a half. Any active infection should be treated, although antibiotics do not reliably reverse arthritis that is already established after an enteric infection. So NSAIDs are first line with DMARDs or biologics therapy reserved for persistent disease. Systemic sclerosis combines autoimmune vascular injury with progressive fibrosis. So limited cutaneous disease mainly affects the distal extremities and is associated with CREST or CREST features, anti-centromere antibodies, and pulmonary arterial hypertension. Diffuse disease extends proximally onto the limbs and trunk and carries greater risks of interstitial lung disease and scleroderma renal crisis. Anti-SCL70 is associated with diffuse disease and interstitial lung disease, while anti-RNA polymerase III is associated with renal crisis. Renal crisis presents with abrupt severe hypertension and acute kidney injury and requires immediate ACE inhibitor treatment. High-dose glucocorticoids can increase this risk. And a little bit of review from our last lecture, but dermatomyositis and polymyositis are inflammatory myopathies that cause symmetric proximal muscle weakness. Patients may struggle to climb stairs, rise from a chair, or lift their arms, and laboratory testing commonly shows elevated CK or creatine kinase and aldolase. So dermatomyositis is distinguished by skin findings such as heliotrope rash around the eyes, Gotron papules over the knuckles, and a shawl or V sign rash. Important complications include dysphagia, interstitial lung disease, and increased malignancy risk, especially with dermatomyositis. Anti-Jo1 suggests anti-synthetase synthetase syndrome, which can combine myositis with lung disease, arthritis, Raynaud phenomenon, fever, and mechanic's hand. Mixed connective tissue disease combines features of lupus, systemic sclerosis, and inflammatory myositis. Raynaud phenomenon and swollen hands are common. Anti-U1-RNP is the characteristic antibody, and pulmonary hypertension is an important complication. Relapsing polychondritis is different. It produces recurrent inflammation and destruction of cartilage. And so the classic finding is always painful red auricle that spares the earlobe because the lobe contains no cartilage. So nasal cartilage may also be affected, and tracheobronchial involvement can become life-threatening by compromising the airways. Hearing loss, ocular inflammation, and aortic involvement may also occur. So septic arthritis is a medical emergency because infection can rapidly destroy articular cartilage. Suspect it in a patient with an acutely painful, warm, swollen joint and severely restricted movement. It is usually monoarticular, with the knee being the most frequently affected joint, and fever may be absent. Important risk factors include older age, diabetes, immunosuppression, IV drug use, a prosthetic joint, recent joint surgery or injection, and pre-existing joint disease. Staph aureus is the most common organism overall, and the practical rule is that an acutely hot and swollen joint should be considered septic until infection has been reasonably excluded. All right, so when septic arthritis is suspected, perform arthrocentesis before antibiotics when the patient is stable and aspiration will not cause a dangerous delay. Synovial fluid should be evaluated for its white cell count and differential. Gram stain, culture, and crystals and blood culture should be also obtained. A high synovial white cell count with neutrophil predominance supports infection, but no single cutoff is perfect. Finding crystals does not exclude simultaneous septic arthritis. Treatment requires prompt IV antibiotics plus drainage of the infected joint. If the patient is unstable, begin treatment immediately rather than waiting for aspiration or culture results. So here's our rapid exam review for this section. So think Ehlers-Danlos when hypermobile joints occur with stretchy skin and poor healing, and think Marfan with the tall patient with ectopia lentis and aortic root disease. Psoriasis with nail pitting and dactylitis suggests psoriatic arthritis, while inflammatory back pain in a young adult suggests ankylosing spondylitis. Multisystem disease with ANA and specific lupus antibody suggests systemic lupus erythematosus, while thrombosis or pregnancy loss with a prolonged PTT suggests antiphospholipid syndrome. Proximal weakness with Gutron papules indicate dermatomyositis. A painful red ear that spares the lobe suggests relapsing polychondritis, and an acute hot joint is septic arthritis until proven otherwise. So vasculitis. So the manifestations of vasculitis often reflect the size of the affected vessels. Large vessel disease can produce limb claudication, absent pulses, unequal arm blood pressure, bruise, or aortic disease. Medium vessel vasculitis more often causes nodules, ulcers. You got digital ischemia, monouritis, multiplex, and renal or mesenteric microaneurysms. Small vessel disease classically causes palpable purpura, glomerular nephritis, pulmonary hemorrhage, and ocular inflammation. Initial evaluation includes blood counts, metabolic testing, inflammatory markers, and urinalysis, followed by target testing such as ANCA, complement, hepatitis serologies, and cryoglobulins. Imaging evaluates larger vessels, while biopsy of accessible affected tissues can establish the diagnosis. So giant cell arthritis is a granulomatous large vessel vasculitis occurring almost exclusively in adults over 50. Classic clues include a new temporal headache, scalp tenderness, jaw claudication, and an abnormal temporal artery, and transient or permanent visual symptoms. Polymyalgia rheumatica causes bilateral shoulder and hip girdle aching with prolonged morning stiffness, but it does not cause true muscle weakness or muscle inflammation. Symptoms often improve dramatically with low-dose prednisone. These disorders frequently overlap, so some patients with polymyalgia rheumatica develop giant cell arthritis, and many patients with giant cell arthritis have polymyalgia symptoms. Any visual symptoms require urgent evaluation. So giant cell arthritis commonly produces elevated ESR in CRP, and a normocytic anemia may also be present. Temporal artery biopsies show segmental granulomatous inflammation, but skip lesions can produce a false negative result. Ultrasound may demonstrate a halo sign around the affected artery, and the crucial point is that the treatment must not wait for biopsy confirmation. Start high-dose glucocorticoids immediately when giant cell arthritis is strongly suspected. Generally, oral prednisone when vision is unaffected, and IV methylprednisolone when vision loss is threatened or already present. An older patient with a new headache, jaw claudication, and visual symptoms must be treated urgently to prevent irreversible blindness. So Takayasu arteries is granulomatous inflammation of the aorta and its major branches. Unlike giant cell arthritis, it classically affects women under or younger than 40 and is more common in Asian populations. Arterial narrowing can cause upper extremity claudication, weak or absent brachial pulses, unequal arm blood pressure, and carotid or subclavian bruits, giving rise to the term pulseless disease. Hypertension and aortic regurgitation may also occur. Diagnosis relies on vascular imaging such as CT and MR angiography. Treatment uses glucocorticoids with steroid-sparing immunosuppression, while revascularization is preferably performed after active inflammation has been controlled. The major ANCA associations are useful patterns, although they are not diagnostic by themselves. PR3 ANCA, usually producing a C-ANCA pattern, is strongly associated with granulomatosis with polyangiitis. MPO ANCA, usually producing P-ANCA pattern, is more commonly associated with microscopic polyangiitis, and eosinophilic granulomatosis with polyangiitis. These small vessel diseases often produce Autoimmune glomerulonephritis and may also affect the lungs, skin, nerves, and upper airway. A negative ANCA does not exclude vasculitis, so biopsy is preferred when practical. Severe organ-threatening disease generally require glucocorticoids combined with rituximab or cyclophosphamide. All right, so granulomatosis with polyangiitis, or GPA, is a necrotizing granulomatous vasculitis involving small to medium-sized vessels. The classic pattern combines upper airway disease, lower respiratory disease, and glomerulonephritis, and upper airway inflammation may cause chronic sinusitis, otitis, nasal ulceration, epistaxis, or destructive changes such as septal perforation and a saddle nose deformity. Subglottic stenosis and strawberry gingivitis are additional clues here, so a pulmonary involvement can produce nodules, cavitary lesions, or life-threatening alveolar hemorrhage. Renal disease usually appears as a rapidly progressive Autoimmune glomerulonephritis, causing hematuria, proteinuria, and red cell casts. GPA is strongly associated with PR3 ANCA, which usually produces a cytoplasmic or C-ANCA pattern. On exam, destructive sinus disease plus cavitary lung lesions and glomerulonephritis should immediately raise concerns for GPA. All right, so microscopic polyangiitis, or MPA, is a necrotizing small vessel vasculitis that differs from GPA because it does not produce granulomatous inflammation. Its major pattern is pulmonary renal syndrome with pulmonary capillaritis, so inflammation of the capillaries, causing alveolar hemorrhage, and Autoimmune rapidly progressive glomerulonephritis, causing hematuria and red cell casts. Patients may also have palpable purpura, mononeuritis multiplex, fever, fatigue, weight loss, and arthralgia. The most useful distinction from GPA is the absence of destructive sinus or nasal disease and the absence of granulomas. MPA is commonly associated with MPO ANCA, which usually gives a perinuclear or P-ANCA pattern. Therefore, when a patient has lung hemorrhage and glomerulonephritis, but no prominent upper airway destruction, microscopic polyangiitis is the more likely diagnosis. Eosinophilic granulomatosis with polyangiitis, or EPGA, or EGPA, is recognized by combination of adult onset asthma, peripheral eosinophilia, and systemic vasculitis. Patients often begin with allergic phase marked by asthma, allergic rhinitis, and nasal polyps, and this may progress to eosinophilic tissue infiltration, producing elevated IgE and migratory pulmonary infiltrates, followed by systemic vasculitis. Vasculitis manifestations include palpable purpura, gastrointestinal disease, and mononeuritis multiplex, which can cause wrist and foot drop. Cardiac involvement, including eosinophilic cardiomyopathy and heart failure, is an especially important cause of morbidity here. And so MPO-ANCA or PANCA is present in only about half of patients. So a negative ANCA does not include EGPA. Treatment is based on the severity and may include glucocorticoids. The anti-IL-5 antibody mepolizumab or rituximab or cyclophosphamide for a major organ system. So the ANCA-associated vasculitides can be separated using a few defining clinical clues. GPA causes destructive sinus and upper airway disease, cavitary pulmonary nodules, and glomerulonephritis, and necrotizing granulomas, and it is most strongly associated with PR3 ANCA or CNCA. MPA also causes pulmonary and renal disease, especially alveolar hemorrhage with glomerulonephritis, but it lacks destructive upper airway disease and granulomas, and it is usually associated with MPO-ANCA or PNCA. EGPA stands out because it occurs in patients with asthma and allergic rhinitis and features eosinophilia elevated by IgE, migratory pulmonary infiltrates, neuropathy, and possible cardiac disease. EGPA may also be MPO-ANCA positive, but only in about half of cases. In short, think destruction and cavitation for GPA, pulmonary renal disease without granulomas for MPA, and asthma with eosinophilia for EGPA. All right, so polyarteritis nodosa, or PAN, is a necrotizing vasculitis of medium-sized arteries that produces segmental fibrinoid necrosis. It has a classical association with Hep B and causes ischemic injury in multiple organs. Mesenteric artery involvement produces postprandial abdominal pain, while renal artery involvement activates the renin-angiotensin system and causes hypertension. Skin findings include livedo reticularis, subcutaneous nodules, ulcers, and gangrene, and other clues include testicular pain and as long as a wrist or foot drop. Segmental arterial weakening and narrowing create microaneurysms and a string of bead appearance on the angiography. A critical distinction is that PAN spares the pulmonary circulation and affects renal arteries rather than glomeruli. I'm so sorry, guys. So it does not cause glomerulonephritis. It is also typically ANCA negative. Diagnosis is made with angiography or tissue biopsy, and treatment includes glucocorticoids, and then cyclophosphamide for severe disease and antiviral therapy when Hep B is present. But on an angiography, this literally just looks like vessels with little balls intermittently along them. Like that whole beading pattern that I reference is quite literally, it does look like little beads. So cryoglobulinic vasculitis occurs when circulating immunoglobulins precipitate at low temperatures and form immune complexes that deposit in small vessels. The major association is chronic Hep C infection. The classic presentation is the triad of palpable purpura, arthralgia, and weakness, but patients may also develop Raynaud's phenomenon, and then peripheral neuropathy, as well as glomerulonephritis. And so laboratory clues include detectable cryoglobulins, a positive rheumatoid factor, and complement consumption with especially low C4. Hepatitis C antibody and RNA testing help identify the underlying cause. Treatment should first target Hep C for another responsible disease, but patients with severe vasculitis or major organ involvement may also require those glucocorticoids and rituximab. And so the exam pattern to remember is palpable purpura and neuropathy or kidney disease in a patient with Hep C with low C4 and a positive rheumatoid factor. Cutaneous small vessel vasculitis, also called leukocytoclastic or hypersensitivity vasculitis, is inflammation of small dermal vessels, often caused by immune complex deposition. Potential triggers include medications, streptococcal or viral infections, autoimmune disease, and malignancy, although many causes remain idiopathic. So the typical presentation is palpable purpura on dependent areas, especially the lower legs, because hydrostatic pressure promotes immune complex deposition there. Lesions can also appear as papules, vesicles, ulcers, or areas of necrosis and arthralgia or myalgia may accompany the rash. Diagnosis is supported by a biopsy of a fresh lesion, often with direct immunofluorescence. Patients should also be screened for renal, pulmonary, gastrointestinal, and neurologic involvement to determine whether the disease is truly skin limited. So management begins by removing the trigger. Mild cases receive supportive care, while persistent disease may require colchicine, dapsone, or glucocorticoids. So Behçet disease, or Behçet disease, I'm not sure how to pronounce the Turkish C there, but it's a variable vessel vasculitis that can involve arteries and veins of any size. The classic presentation includes recurrent painful oral ulcers, and so recurrent genital ulcers, uveitis, and inflammatory skin lesions. Uveitis may produce a hypopyon, which is a visible collection of inflammatory cells in the anterior chamber. So you're quite literally seeing immune cells. Other manifestations include erythema nodosum, like a papulopustular lesion, non-erosive arthritis, thrombophlebitis, and then gastrointestinal or central nervous system disease. Because both arteries and veins can be affected here, patients may develop venous thrombosis, arterial occlusion, or aneurysms. Pathergy is a characteristic clue here. So minor sterile trauma, such as a needle prick, produces an exaggerated papule or pustule. And so diagnosis is clinical because no single laboratory test is specific here. Treatment depends on organ involvement and ranges from topical steroids for limited mucocutaneous disease to systemic glucocorticoids, immunosuppressive agents, or anti-TNF therapy for major organ disease. IgA vasculitis, formerly called Henoch, Swedish last name purpura, is the most common systemic vasculitis of childhood and often follows an upper respiratory infection. Its classic tetrad includes palpable non-thrombocytopenic purpura, arthralgia or arthritis, colicky, abdominal pain, or gastrointestinal bleeding, and glomerulonephritis with hematuria. The rash is usually concentrated on dependent areas, particularly the buttocks and lower extremities. Pathology shows a leukocytoclastic small vessel vasculitis, while direct immunofluorescence demonstrates granular IgA deposition. The disease is ANCA negative. Most childhood cases resolve spontaneously but can be treated supportively, but renal involvement determines the long-term prognosis. For that reason, blood pressure, serum renal function, and urinalysis should be monitored even after the rash and abdominal symptoms improve. And on an exam, think IgA vasculitis when a child develops palpable leg and buttock purpura, joint pain, abdominal pain, and hematuria after a respiratory infection. Primary angiitis of the central nervous system is the inflammatory vasculitis confined to vessels of the brain and spinal cord. It can present with persistent headache, encephalopathy, cognitive changes, seizures, or recurrent strokes involving multiple vascular territories. MRI commonly shows multifocal abnormalities, while angiography may demonstrate alternating areas of stenosis and dilation. However, this angiographic beating is not specific, so imaging can support but cannot definitively establish the diagnosis. Brain or leptomeningeal biopsy provides the most definitive confirmation here. So before diagnosing primary CNS angiitis, important mimics must be excluded, including infection, systemic vasculitis, Behçet disease, cocaine exposure, and reversible cerebral vasoconstriction syndrome. So the distinction from reversible cerebral vasoconstriction syndrome is especially important because that disorder often presents with thunderclap headaches and does not require long-term immunosuppression. So primary CNS angiitis is generally treated with glucocorticoids with additional immunosuppression for severe disease. All right, so Buerger disease, also called thromboangiitis obliterans, is an inflammatory thrombotic disease of small and medium-sized vessels that is tightly linked to tobacco exposure. So the classic patient is a heavy tobacco user younger than 45 who develops ischemia of the fingers or toes. Poor distal blood flow causes pain, Raynaud's phenomenon, non-healing ulcers, and eventually gangrene or auto amputation. Superficial thrombophlebitis and abnormal Allen test may provide additional clues. Angiography classically shows abrupt cutoffs in distal vessels with corkscrew-shaped collateral vessels forming around the obstruction. The most important treatment is to complete tobacco and nicotine cessation. Reducing tobacco use is not enough, because even continued low-level exposure can allow the disease to progress. So the easy exam association is a young tobacco user with painful ischemic digits and distal gangrene. So not every case of vasculitis represents a primary autoimmune disorder. Similar vessel inflammation can occur secondary to lupus, rheumatoid arthritis, malignancy, medications, cocaine. And so infections are particularly important because immunosuppressing an unrecognized infection can be dangerous. Remember, the major viral pairings, hepatitis B is associated with polyarteritis nodosa, while hep C is associated with cryoglobulinemic vasculitis. So HIV and varicella zoster can involve cerebral vessels and produce CNS vasculitis, and meningococcal, gonococcal, syphilitic, and rickettsial infections can also produce vasculitic or vasculitis-like presentations. The practical rule is that before beginning intensive glucocorticoid or other immunosuppressive therapy, actively exclude infection and review the patient's medication, substance exposure, autoimmune history, and malignancy risk. Several clinical combinations should trigger immediate pattern recognition. In an older patient, a new headache with jaw claudication and visual symptoms suggests giant cell arthritis. Begin glucocorticoids immediately to protect vision and do not delay treatment for a temporal artery biopsy. Hemoptysis, a failing hemoglobin and or a falling hemoglobin and red cell casts indicate pulmonary renal syndrome. So with a differential including GPA, MPA, anti-GBM disease, and lupus. Abdominal pain, hypertension, and neuropathy without pulmonary involvement suggest polyarteritis nodosa. Asthma, eosinophilia, and neuropathy point towards EGPA. Recurrent oral and genital ulcers with painful red eye suggest Behçet's disease with potential vision-threatening uveitis. And finally, a child with palpable purpura, abdominal pain, and hematuria likely has IgA vasculitis, and these combinations matter because they either identify an emergency or sharply narrow the differential. It's time for that rapid exam review. So for rapid recall, connect each vasculitis to its most distinctive presentation. So an older adult with a headache and jaw claudication, giant cell arthritis, while shoulder and hip stiffness that rapidly improves with low-dose steroids suggests polymyalgia rheumatica. A young woman with unequal arm pressure suggests Takayasu arteritis. And then you got destructive sinus disease, cavitary lung nodules, and glomerulonephritis, indicating GPA, whereas pulmonary renal syndrome without significant ENT disease favors MPA. And then you have asthma with eosinophilia and a neuropathy, which is EGPA, and then mesenteric ischemia, renal microaneurysms, and no glomerulonephritis indicate PAN or PAN. Hepatitis C, purpura, arthralgia, and low C4 or complement suggest cryoglobulinema. Okay. Isolated palpable purpura after a new medication suggests cutaneous small vessel vasculitis. Oral ulcers, genital ulcers, and uveitis indicate Behçet's disease. A child with purpura, abdominal pain, and hematuria has IgA vasculitis, and a young tobacco user with distal gangrene has Buerger's disease. Sjögren syndrome is an autoimmune lymphocytic destruction of exocrine glands, producing the classic combination of dry eyes, dry mouth. It may also occur alone or accompany rheumatoid arthritis, lupus, or systemic sclerosis, and most often affects the middle-aged women. So dry eyes feel gritty or sandy, while reduced saliva causes difficulty swallowing dry foods, dental caries, altered taste, and parotid enlargement. Anti-Rho or SSA and anti-La or SSB are the characteristic antibodies, and objective testing includes it's called the Schirmer test, ocular staining, and minor salivary gland biopsy. And then you have systemic complications, including inflammatory arthritis, interstitial lung disease, neuropathy, purpura, and distal type 1 renal tubular acidosis. Anti-SSA can cross the placenta and cause neonatal lupus or congenital heart block, and Sjögren syndrome increases the risk of MALT and other B-cell lymphomas. Treatment begins with artificial tears and saliva. Remember pilocarpine and cevimeline as muscarinic drugs that turn secretions back on, so sweating is an expected adverse effect here. Rheumatoid arthritis for the 100th millionth time. So rheumatoid arthritis is a chronic autoimmune synovitis that forms an inflammatory pannus, which progressively destroys cartilage, bone, tendons, and ligaments. It causes symmetric pain and boggy swelling of wrists, MCP joints, and PIP joints, while usually sparing the DIPs. Morning stiffness lasts longer than an hour and improves with activity. Anti-CCP is a more specific antibody and predicts erosive disease, while rheumatoid factor is less specific. Imaging may reveal uniform joint space narrowing and marginal erosions. Extra-articular findings include rheumatoid nodules, interstitial lung disease, scleritis, pericarditis, atlantoaxial instability, and Felty syndrome, which combines rheumatoid arthritis, splenomegaly, and neutropenia. So treatment should begin early with disease-modifying drugs. Methotrexate is the usual anchor drug here. So remember that it's once-weekly medication given with folic acid that can affect the liver, marrow, lungs, and pregnancy. NSAIDs relieve the pain but do not prevent joint destruction, while biologics target the pathways such as TNF, IL-6, B cells, or T cell activation. Okay, so osteoarthritis is the most common joint disease and results from progressive cartilage loss while remodeling of subchondral bone. Clinically, it behaves like a mechanical disorder. Pain worsens with activity and improves with rest. Morning stiffness usually lasts less than 30 minutes, and examination shows crepitus, limited motion, bony enlargement, and a cool rather than intensely inflamed diffusion. Imaging demonstrates non-uniform joint space narrowing, osteophytes, subchondral sclerosis, and subchondral cysts, while synovial fluid is non-inflammatory with fewer than about 2,000 white cells per cubic millimeter. Osteoarthritis commonly affects the knees, hips, spine, first MTP, first CMC, DIP, and PIP joints. In contrast, rheumatoid arthritis produces prolonged morning stiffness, boggy synovitis, marginal erosions, and symmetric MCP, PIP, and wrist involvement. A simple memory rule is that osteoarthritis is bony and worse with use, whereas rheumatoid arthritis is boggy and improves with use. So early osteoarthritis is in an unusual joint should prompt evaluation for secondary cause. All right, so for hand osteoarthritis, remember Haberdine nodes at the DIPs, and you can remember that because Haberdine is high, so it's higher up on your hand. And then Bouchard nodes at the PIP joint. So just remember Haberdine is high, Bouchard is lower, so it's going to be the PIPs. First, CMC disease causes pain at the base of the thumb, and then erosive hand osteoarthritis is more inflammatory variant seen especially in postmenopausal women and can mimic inflammatory arthritis, although rheumatoid serologies and inflammatory markers are generally negative. In the spine, degenerative stenosis produces neurogenic claudication that worsens with standing or walking and improves with sitting or leaning forward. DISH or DISH is recognized by flowing ossification of the anterior longitudinal ligament across at least 4 contiguous vertebrae with preserved disc spaces and no sacroiliitis. It is associated with older age, obesity, and type 2 diabetes. Osteoarthritis treatment starts with exercise, weight reduction, therapy, and mechanical support. Topical diclofenac is an easy first medication to remember because it treats localized pain with less systemic exposure. Oral NSAIDs and joint injections may help selected patients, while joint replacement is reserved for severe pain and functional loss. All right, so topical medication vehicle. So the vehicle carrying a topical medication affects where it works best and how well patients tolerate it. Ointments are greasy but highly occlusive, so they enhance hydration and medication absorption and are best for dry, thick, or scaly lesions. Creams are less greasy and are more cosmetically acceptable, making them the versatile everyday option for inflammatory rashes, although they are less occlusive than ointments. Lotions, solutions, and foams spread easily through the hair, so think of them for the scalp and other hair-bearing areas. Their main drawbacks is that they can be less hydrating or may sting. Gels dry quickly and work well on oily or acne-prone areas, but can also be drying or irritating. The simplest memory rule here is that ointments for dry and thick, lotion for foam or hair, and then gel for oily skin, and cream for when you need a practical middle ground option. All right, so topical corticosteroids are easiest to remember as a potency ladder matched to the skin thickness. So hydrocortisone is a low potency, gentle option used on thin or sensitive areas such as the face, skin folds, and genitals, as well as in children. This is usually like first line acne medication for like a teenager. So then we have triamcinolone, I'm so sorry about the pronunciation, guys, which represents the middle of the ladder and is commonly used for moderate inflammation of the trunk and extremities. And then you have betamethasone and fluconamide, which represent higher potency choices for more severe inflammation or thicker skin. And then you have clobetasol, which is the super high potency option reserved for thick plaques or palms and soles, and it should only be used in short courses. And so the memory rule is low potency for thin skin and high potency for thick skin. So potency also rises with occlusion, particularly when an ointment is covered. So excessive use can cause skin atrophy, striae, telangiectasias, and systemic absorption. So stronger steroids require smaller treatment areas and shorter durations. Some of the easy things to remember about these guys is hydrocortisone. I just always remember is the starter guy, lowest one. But betamethasone, I just remember it's beta, so it's the highest potency one. It's a higher one. And then the other one that I have an easy way to kind of remember is clobetasol, right? So I just remember clobetasol, and I think of a club, and you use a club with your hand, so it's going to be touching the palm. So I just remember that one's used for the really thick parts of your body, like the soles of your feet, your hands, etc. All right, so topical corticosteroids are the standard first-line anti-inflammatory treatment, but potency must match that location and severity of disease. So again, use weaker steroids on the thin or sensitive skin and a stronger steroid for the thick plaques, remembering that prolonged or extensive use can cause skin atrophy and systemic absorption. Tacrolimus and pimecrolimus are steroid-sparing calcineurin inhibitors that are especially useful for atopic dermatitis of the face, eyelids, and skin folds because they do not cause atrophy. Their signature adverse effect is temporary burning or stinging, and both carry a boxed warning. Then you have crisborol, which is a topical PDE4 inhibitor, while topical ruxolitinib blocks JAK signaling. So again, you have that nib returning to indicate it's a JAK inhibitor. Both provide non-steroidal options, so more persistent, moderate to severe disease may require dupilumab, which blocks IL-4 and IL-13 signaling and is associated with conjunctivitis, or an oral JAK inhibitor, which works quickly but requires closer monitoring for serious infections and other boxed warning risks. So now, again, if I were to break up each of these drugs and give them their own slide, this video would be 1,000,000 hours long. So I'm just going to breeze through these and give you just quick associations here. So anti-infective dermatologic agents. So the easiest way to organize these skin anti-infective is by organism and depth, right? So mupirocin treats localized superficial bacterial infections such as impetigo, but topical drugs do not penetrate deeply enough to treat cellulitis. Non-purulent cellulitis usually needs streptococcal coverage with beta-lactams such as cephalexin, while purulent infections require drainage and consideration of MRSA active drugs. Neomycin and bacitracin are notable causes of allergic contact dermatitis. For fungi, azoles treat both dermatophytes and candida. Terbinafine is especially effective against dermatophytes and is commonly used orally for nail disease, and nystatin treats candida, but not dermatophytes. Remember oral terbinafine for liver toxicity concern. Then you have griseofluven is an older oral option classically associated with tinea capitis. Acyclovir and valcyclovir treat HSV and VZV, especially when started early. And then you have permethrin, which is a first-line treatment for scabies and lice, while ivermectin, read the lowercase I as an L, that's my bad, or uppercase I as an L, that's my bad. Ivermectin, which is useful for difficult or crusted scabies. And then you got seborrheic dermatitis, which is treated with anti-malassezia agents such as ketoconazole or selenium sulfide. Okay, so acne treatment becomes easier when each drug is matched to one part of the disease. So comedones result from abnormal follicular plugging, so topical retinoids normalize keratinization and keep follicles open. Okay, so benzoyl peroxide decreases Cutibacterium acnes and inflammation and is often paired with a topical antibiotic. Moderate inflammatory acne may require an oral tetracycline such as doxycycline for its antibacterial and anti-inflammatory effects. When acne follows a hormonal pattern, combined oral contraceptives or Spironolactone reduce androgen-driven sebum production. Severe nodulocystic scarring or treatment-resistant acne calls for isotretinoin, the most comprehensive systemic therapy because it reduces sebum, follicular plugging, bacteria, and inflammation. Rosacea is different because it does not feature comedones. So papulopustular rosacea is treated with agents such as topical metronidazole, azelaic acid, or ivermectin. The basic sequence is retinoids for plugging, benzoyl peroxide for bacteria, tetracyclines for moderate inflammation, and then hormonal therapy for androgen influence, and isotretinoin for severe scarring disease. All right, so now we just have a quick summary here for our acne and rosacea agents. So benzoyl peroxide reduces Cutibacterium without promoting antibiotic resistance. Its memorable adverse effects are dryness, irritation, and bleaching of towels or clothing. Topical retinoids such as tretinoin, adapalene, and tazarotene prevent comedones but can cause peeling and photosensitivity and are generally avoided during pregnancy. Topical clindamycin or erythromycin should not be used alone because resistance develops pretty quickly, so pair them with benzoyl peroxide. Oral doxycycline or minocycline treats moderate inflammatory acne, but tetracyclines can cause GI upset and photosensitivity and are avoided during pregnancy and in young children. Do not combine tetracyclines with isotretinoin because both can increase the risk of intracranial hypertension. Isotretinoin is reserved for severe scarring or refractory acne. Remember, extreme mucocutaneous dryness, tetragenicity, and lipid and liver enzyme monitoring. Spironolactone is useful for hormonally influenced acne, but can cause hyperkalemia and menstrual changes. So for papulopustular rosacea, remember metronidazole, azelaic acid, or topical ivermectin. Okay, so localized plaque psoriasis is usually treated with topical corticosteroids with potency matched to the plaque thickness and body location. Calcipotriene and calcitriol are vitamin D analogs that regulate keratinocyte growth and provide steroid-sparing therapy. Excessive use rarely causes hypercalcemia. For more extensive disease, methotrexate is a once-weekly systemic option associated with liver, marrow, lung, and pregnancy toxicity with folic acid used to reduce adverse effects. Cyclosporin works quickly in severe disease, but the iconic toxicities are nephrotoxicity and hypertension, so think cyclosporin saves quickly but costs the kidneys. And then you have biologic targets like TNF, IL-17, IL-23, or IL-12/23, and requires screening for latent infections. So retinoids such as topical tazarotene and oral acitretin are highly teratogenic, with acitretin requiring an especially prolonged pregnancy avoidance period. Apremilast is an oral PDE4 inhibitor associated with gastrointestinal effects, weight loss, and mood concerns. Phototherapy treats more extensive disease but carries cumulative ultraviolet light risks. All right, so these medications target excessive keratin or abnormal cellular growth. So salicylic acid is a keratolytic that breaks down thick keratin, making it useful for common warts and hyperkeratosis lesions. Extensive use can produce salicylate toxicity, especially in children or under occlusion. Topical fluorouracil kills rapidly dividing abnormal cells and is used for actinic keratoses and selected superficial basal cell carcinomas. Redness, crusting, and erosion are expected signs of its local treatment effects. Imiquimod stimulates a local immune response and can treat external genital warts, actinic keratoses, and superficial basal cell carcinoma. Local inflammation and occasional flu-like symptoms may occur. Podophylox directly destroys external anogenital warts and is avoided during pregnancy. Urea both hydrates and softens thickened skin. So then photodynamic therapy uses a light-activated drug for actinic keratoses, making photosensitivity precautions essential here. So finally, vismodegib and sonidegib block hedgehog signaling and are reserved for advanced basal cell carcinoma, with teratogenicity being a major concern here. And I always just remember that sonidegib is used for hedgehog because sonic, but then I just remember the degib is part of vismodegib again, so I remember that it has to do with hedgehog. And finally, we're just going to wrap up with a little bit of pediatrics here. So measles begins with high fever in the 3 C's, which are cough, coryza, and conjunctivitis. Koplik spots are tiny white grains of salt on the buccal mucosa, followed by the maculopapular rash that begins near the hairline or behind the ears and spreads downward, often becoming confluent. Mumps is best remembered for the painful parotid swelling, with important complication including orchitis, pancreatitis, and aseptic meningitis. Rubella is typically milder, producing a pink rash that begins on the face and spreads downward, along with post-auricular and suboccipital lymphadenopathy. Rubella was traditionally grouped with togaviruses, although its modern classification has changed. Its greatest danger is infection during pregnancy. Congenital rubella produces the classic triad of cataracts, sensorineural deafness, and patent ductus arteriosus, and may also cause blueberry muffin lesions. The MMR vaccine is live attenuated, so it is contraindicated during pregnancy. I always remember rubella from the rest of these because rubella is kind of rude. One of my friends gave me that, and so it's rude because it can basically kill the baby before it even has time to really enjoy life. So there you go. I just remember rubella because of the blindness and the deafness. Like literally the baby's coming out and it can't see and can't hear. That's kind of messed up. All right, varicella causes intensely pruritic vesicles that appear in successive crops, so lesions in multiple stages from vesicles to crusts are visible simultaneously. Arrhythmia infectiosum is caused by parvovirus B19 and produces bright slap-cheeked rash arrhythmia, followed by lacy rash on extremities. Beyond the rash, remember B19 for transient aplastic crises and fetal hydrops. Honestly, parvovirus B19, even though like the slap cheek rash is such a nice buzzword to remember it by, literally I've never gotten it on any exam, and it is like they love to be super secretive with this one for some reason. It can also cause what's called fifth disease. Okay, so remember that for parvovirus. That one's usually they like to make that one tricky for whatever reason. Hand, foot, and mouth disease is usually caused by Coxsackie virus and produces macules or vesicles on the hands, feet, and oral mucosa. Treatment is supportive with hydration as the main concern because oral lesions can limit intake. Roseola causes several days of sudden high fever, sometimes with febrile seizures, followed by a trunk-centered maculopapular rash that appears as the fever resolves. Molluscum contagiosum produces those smooth, flesh-colored dome-shaped papules with characteristic central umbilication. The quickest distinctions are crops of lesions for varicella, slap-cheeked for B19, but again, be careful with that one. Palms, soles, mouth for Coxsackie virus, fever, then rash for roseola, and then umbilicated papules for molluscum. And remember, that's caused by pox virus there. So fever with rapidly spreading, non-blanching petechiae or purpura should be treated as meningococcemia until proven otherwise. Meningococcemia until proven otherwise. The rash may progress to widespread hemorrhage, and cultures or PCR can support the diagnosis, but emergency antibiotics should not be delayed in a critically ill patient. Impetigo is a superficial infection caused most often by Staph aureus or Strep pyogenes and produces vesicles or erosions covered by honey-colored crusts. Localized disease can be treated with topical mupirocin, while extensive disease may require oral antibiotics. Scarlet fever results from toxin-producing group A strep and causes a fine sandpaper-like rash, strawberry tongue, and circumoral pallor. So erythema marginatum is different here. So it is transient, expanding annular rash with central clearing that appears weeks after an untreated streptococcal infection, and it is one of the major Jones criteria for acute rheumatic fever and should prompt evaluation for associated carditis, migratory arthritis, chorea, or subcutaneous nodules. Finally, so we have Candida dermatitis, which produces a beefy red eruption in the moist skin folds with characteristic satellite papules for pustules. In diaper dermatitis, Candida involves the creases, whereas simple irritant dermatitis tends to spare them. Treatment is topical azole or nystatin. Tinea corporis, or ringworm, is a dermatophyte infection that forms an annular, slightly raised plaque with peripheral scale and central clearing. It spreads through direct contact and is treated with topical antifungals such as terbinafine or an azole. Scabies causes severe itching that is classically worse at night, with thin burrows commonly found in between the fingers, around the wrists, and in other skin folds. Permethrin is the standard first-line treatment there, but successful management requires treating close household contact at the same time and washing or isolating contaminated clothing and bleeding and bedding, not bleeding, clothing and bedding. The fast recognition pattern is satellite pustules in folds for Candida, a scaly ring with a central clearing for tinea, and nocturnal itching with interdigital burrows for scabies. All right, so atopic dermatitis is a chronic, intensely pruritic condition that commonly begins in childhood and fluctuates with environmental or seasonal triggers. Repeated scratching disrupts the skin barrier, producing excoriations, thickened or lichenified skin, and susceptibility to secondary infection. Treatment centers on regular use of thick moisturizers, avoidance of known irritants, and appropriately potent topical corticosteroids during flares. Seborrheic dermatitis is distinguished by the greasy yellow scale on erythematous base. So in infants, it produces a cradle cap during the first weeks of life, while older patients commonly develop involvement of the scalp, eyebrows, and nasolabial folds. IgA vasculitis, formerly the Henoch, Swedish last name purpura, presents differently, so with palpable non-blanching purpura concentrated on the legs and buttocks, often accompanied by abdominal pain, arthritis or arthralgia, and hematuria. Most childhood cases resolve spontaneously, but blood pressure, urinalysis, and renal function require follow-up because kidney involvement determines long-term risk. And so the three major vascular birthmarks are separated by whether they persist, enlarge, or fade. A capillary malformation or a port wine stain is a flat, dark red purple lesion that is present at birth, persists, and grows proportionally with the child. A facial lesion involving the forehead or upper eyelid should raise concern for Sturge-Weber syndrome and its associations with seizures and glaucoma. An infantile hemangioma is a raised bright red strawberry lesion that may be subtle or absent at birth, enlarges rapidly during the first months, and then usually involutes during childhood. Most only require observation, but hemangiomas threatening vision, breathing, feeding, or permanent disfiguration are treated with propranolol. And then you have, remember to give the propranolol with feeds because hypoglycemia is an important risk here, along with bradycardia and hypotension. Nevus simplex, or an angel's kiss or stork bite, which I think is a great name for it, is a flat pink-red mark that usually fades during early childhood, although lesions on the posterior neck may persist. In short, you got port wine stains that persist, hemangiomas grow and then involute, and then the nevus simplex, which usually fades. All right, folks, thank you so much for making it through another episode of MooseMed with me. That is going to put a wrap on MSK Week 2 and MSK II in general. So I'll be taking a bit of a break during this next system in my course, and I'll pick it back up when we start CV Resp, which is going to be a doozy. I got 4 weeks for that one. Okay, so yeah, thank you guys. I hope this nets you some points on exams. Sorry for the pronunciation as always. My kitty Otter says hello. She's sleeping on the chair behind me. Thank you as always for stopping by MooseMed, where we take medicine by the horns, but for all intents and purposes, moose have antlers. Thank you guys as always. Have a good rest of your day.